Oh, good morning, everyone.
It's beautiful there.
Online folks, hopefully just confirming you can hear us okay. Erica, if you give us a thumbs up. You heard your name, great. So just confirming, I am going to turn my video on this laptop so you can see me. The commissioner will be joining us in a few minutes, but we wanted to try to get started just because we know this will be a really important conversation. We want to make sure we have time for that. So just a few housekeeping things. There are snacks, some coffee back there. Please get whatever you need. There's some bathrooms out close to where you came in. If you go down the walkway, you'll see some bathrooms by the elevators. And there's Wi-Fi in terms of the login on the board there. So for those in person, if that's helpful. And then we will be trying to, when the teams are speaking, we'll try to keep the video on our laptops so that those online can at least see us a little bit easier, including the room, at least for the purposes. For questions and discussion, we probably will just not do that because it's obviously a little bit, but if we need to, we can always revert to that. So I think that's.
And it seems like the technology is working better than last time. So that's a lot of, that's good progress.
Yeah. Yes. So I think we'll jump right in and just kind of a reminder of our agenda for today. We'll be doing some opening remarks, review of progress today, and talking about a payment model overview and examples. And then we'll jump into our conversations of putting off and direction with that on base payment as well as performance-based payment. There'll be a break between those. And then we'll have some closing remarks and next steps. So in terms of next slide, we'll kind of just a reminder of our design goals. So this is really conducted with the overarching goal to think about how do we improve the biopsychosocial well-being of key members, especially for the most historically disadvantaged. Commissioner, good morning. In a way that reduces inequities, frictions. Again, acknowledging that primary care is not the whole solution to this. We know this, but we think it's a really important part of this, of what we can do to improve the high functioning healthcare system. And then this committee's charge is really engaging critically with the DSS team to develop a primary care program that promotes health equity, improves health and well-being of our members. So we're really looking for you for input and advice. And we really appreciate the engagement to date. And we anticipate continuing this kind of some hybrid meetings where we will have some in person, we'll have some that are just purely virtual. So we look forward to continuing that. Next slide. And just as a reminder on opportunities ahead, and so there's a little bit, we did modify based off of your feedback, opportunity number 4 here, but addressed disparities in quality of care and member outcome. We reviewed this a little bit previously in some of our data. We know that there's opportunity there. Ensure members have easy and timely access to care and address the range of barriers that make it challenging for members to access care. This has come up over and over again, especially access to care, and I know that will come up in today's conversation as well. Acknowledge the role that social determinants of health play in member health and well-being, and better identify and address health-related social needs. Again, one of the priority areas that's been identified. Enhance team-based care with a focus on improving the care experience and providing care coordination driven by person-centered goals and needs. Again, another one of the care delivery priorities is team-based care. Improve chronic condition management with a focus on reducing unnecessary inpatient ED utilization. Again, another one of our priorities. And invest more in primary care as a percent of total spend with the intent to increase preventive care and preventive care spending and decrease acute care spending.
I'd like to respond to this before we move on, and that is that, well, I think in taking back the materials to our members and discussing it more broadly, and recognizing that reference was made to behavioral health embedded within improved chronic conditions management or team-based care, we're troubled by the fact that it's not more prominent given behavioral health is, well, there's, I don't want to call it a crisis or near epidemic, but the behavioral health rates of presentation EDs and other settings has really grown tremendously. And one wouldn't know, the average layperson or clinician whom you're communicating with, that behavioral health is on the radar. So while it's something that's been discussed in the group, we had talked about a specific objective or opportunity that made behavioral health explicitly more prominent. And the data we have shows that 45% of people with diabetes present depression, 45% who present to the hospital have substance use disorder, and And then as your own prevalence data suggests, it's 3 times this next most prevalent condition. So I'd strongly encourage us to reconsider whether behavioral health could be spiked out as its own, behavioral health integration as its own objective.
Appreciate that. I think, I suspect everyone agrees that it's such an important topic, and we can take that back and figure out how we can incorporate that into the moving forward. Because I think based on the conversations we've had, and I think what you're, Mark, just make sure I'm hearing what you're saying, is really just make sure it's prominent so that if other people are viewing this, they really understand that, to understand that it is a priority of the discussion that's gone on. Does that sound right? Yeah. Great. Yeah, we definitely can take that back, I think. I think we're aligned and agreed that it's really, really important, and want to make sure that it's called out and can, how we can make that a more prominent point of this moving forward. All right, I think we can go to the next one, and then I will. If you want to hop in, feel free to. I know you will. Let's go over the goals if you'd like to.
No, we should keep going. Thank you, Tim. What's going on there?
Can those online still hear us okay? Okay,
Yes.
so I think we're okay. Hopefully Zoom will not quit on us. So our goals for today are really, again, to take stock of where we are, where we've come to date, and orient us towards the goals and really decisions that we've discussed along the way, and then talk about the care delivery system and how we can orient that with payment models. And so we're going to start by providing an overview of payment models, and we'll talk about level set what some language and how we can talk about it, and then really think about, again, payment models through the lens of what are our goals and objectives and our care delivery priorities. And then we're going to collect directional feedback from all of you about where we think the strengths and limitations of these models, as well as what's best suited to actually drive our priorities and the priorities that we've discussed today. So that's kind of where we'll be headed. And I think, I'm gonna turn it over to you, unless Commissioner, you want to say anything at the top, or we'll give you a chance later if you'd like to.
Okay, so thank you, everyone. Actually, there's something going on in one of our Waterbury offices, nothing in particular, it's just, they're old and it's not great. So I had to deal with that first. So I'm sorry, I'm a little, thank you for being here. I know that these in-person and hybrid meetings are always a significant commitment in the morning. I also wanted to just say Happy New Year to everyone and thank you for being here. The other thing is that I have not been able to attend every meeting, but I'm just really grateful for the commitment that you've made and all the progress that we're making towards building these models. I'm really looking forward to what we'll be able to accomplish today. And I'm going to turn it back over to you, Brad. Yeah.
Great, and I think, thank you. I'm glad you're here. We totally, these crises unfortunately come up, and we know a lot of it lands on your shoulders, Commissioner, so we appreciate you being here.
You know, everything from like, why is there no water to, I'm like, I don't know. To dealing with the big, really, right, important things of primary care payment.
Guy, I think I'm going to turn it over to you to talk about why we were here today.
Okay, great. I want to, in 5 minutes, try to just reorient us to how we got here, because I think that's important before we launch ahead. And on the next slide, it's actually not on the slide, but I think it's important to remind ourselves, is that we started by listening, primarily to our members. So we conducted a number of listening sessions with our members, also with providers, also with advocates. You'll recall, think way back to the spring and summer with the quantitative data, kind of trying to get the member voice through the survey data and utilization data that we had. We had kind of the fact pack. And we also have our regular touch points with our membership that informed some of the goals. Okay. We took all that information, we're kind of distilling it down, and today is the meeting where we're moving from the what are we focusing on to what are we going to actually do to try to make a difference. So care delivery, the first we said we focused on what are the things we want to focus on. We then talked for the last 2 meetings on how we were going to measure it. We talked about process measures, we talked about outcomes measures, we talked about some measures span across, some are more specific. And then today is the payment. So this is how are you going to pay? Because Medicaid DSS that's the main tool that we have. So that's kind of a really quick summary. On the next slide, just a little bit more detail. On an October 26th meeting, we took all those data points, the qualitative, the quantitative feedback, the input from advocates and providers, and we collectively identified 5 areas that we really wanted to focus on: chronic condition and targeted case management, accessibility, health-related social needs, data and infrastructure, and team-based care. So you may recall, I think we were in this room, I'm not totally sure, we voted, we kind of had some discussion trying to get on those 5 priorities. In the last 2 meetings, November 14th and December 7th, we talked about the measurement. In the appendix, we have some of the measures that we talked about during those 2 meetings. But just to remind you, 2 big classes, so the process measures, things like eye exams for people with diabetes, and their outcomes measures, things like avoidable hospitalizations and ED visits. And then today, we're talking about the money. And then on the last slide, kind of on the way back machine here, I'm not going to read every word on this slide, but I do think it's worth just dwelling for a moment on slide 9 on those 5 priorities, because at least the way I'm coming to this conversation, and I think the DSS team as well, is we've really been listening to you all on what we and our members think are important. And I want to make sure that when we start to think about the money and how we pay, that we're thinking carefully about these 5 goals, right? I think it's very easy to get caught up in the details and the complexity of the payment model, and there are a lot of them, but I think it's really good to recenter on what's the problem that we're trying to solve. So just to say again, the first one on chronic condition management and targeted case management, this is kind of encouraging primary care providers to, for example, use evidence-based guidelines to treat chronic conditions, very much including behavioral health stuff. So Mark, I hear you, and we'll think about how to fold that in. On the accessibility, we spent a while talking about what we mean by accessibility. And I think we came to some pretty good understanding. And I'll just flag that I think we had some really good discussion about accessibility might mean different things to different people. Accessibility might mean something different for one of our members with disabilities than a member without, or a member who doesn't speak English as their primary language. And in the measurement section, we talked about how to pick up and think about those various definitions of accessibility and how we might measure them. Third, on the health-related social needs, we just remember we had a good discussion about what the role primary care should play. We talked about the 3 different kind of motifs, and the consensus of the group in general was to land in the middle rather than doing nothing or kind of treating and trying to address all the health-related social needs. We landed more on the screening and referring. On the data and infrastructure, this is using kind of the backbone, using electronic health record and others to help integrate data from our members. And then team-based care, recognizing the important role of both clinical and non-clinical personnel. All right, I just summarized like 9 months worth of meetings in 5 minutes. Hopefully that helps though. And again, when we were thinking about the money, I want us to think about these 5 priorities. Maybe if you want, you could actually rip it out of your slide. I'm going to do that just so I have it right next to me when I'm thinking about that. Any questions or any things that folks want to bring up looking backwards before we start moving forwards? We're on the same page kind of with how we got here and what we're trying to solve.
I have a quick.
Yes, great. Thank you.
So the referral to address the member's need is not the funding discussion is not going to include the referral group. Am I correct? You're really talking about funding it within the primary care, funding whatever happens within the primary care.
That's Alice. Let me play back what I think I heard to make sure I'm getting your question. Was your question, hey, Guy, there is the referring, but then there are all the entities that are going to need to take those referrals. And is your question, what's in scope for today's discussion? Is it the money to do the referrals or the money to do the service delivery? Is that your question, Alice?
Yes.
Great. I really appreciate the question. The scope of today's discussion is the former, not the latter. It's the financing for primary care, including the referral. Out of scope for today, although it's obviously very important, is the broader health-related social needs. How is the state funding the social safety net health outside of primary care? Any other No, this is a great question.
I think it just makes a really good point that screen and refer to a waiting list doesn't help anybody.
Yeah.
And if we're not, there has to be some kind of commitment that we get that. You can't just talk about, too many people just talk about social needs and they don't end up doing anything. And so again, it's another TBD, which just drives me up the wall because we never get to those and we underfund those. So I think it's really important to put, not a pin, like a spade in that.
Okay.
That without that, none of this works.
And I hear you, Ellen, and when I think I literally waved my hands a little bit when I said that in general, the consensus of the group was this. I know you don't share that consensus.
Come up a lot.
Yeah, no, that's fine. And I hear you on the spade.
Can I ask a question?
Please, yeah.
I absolutely agree. Karen Daly and I represent Optimus Healthcare and we're a federally qualified health center, and we serve marginalized communities. And when you talk about referrals, the population that we serve is going to be on a waiting list. And so if the general consensus is that works for other communities, can there be something different for marginalized communities so that we do have funding so that we can continue, because we already provide this, so we can continue to provide the services that are needed for them to be able to access healthcare?
I hear you. I don't have a solution.
I know, well, I agree that if it's the group, but I think when we talk about different communities, I don't think that we can consider marginalized communities and those that live in suburbs accessing primary care are the same, because it's not.
Mhm.
And so there can't be one solution that fits all, because that's not gonna happen.
And I think
It's very, very different.
as to say, I think definitely will come up today in terms of the various needs. I think just as you kind of outlined, like the scope of what we're addressing is around the payment to providers, specifically understanding that there are a lot of needs outside of obviously what primary care can do. And I think acknowledging it's not the only solution. There is a huge need for health related social needs, both access to services that aren't realistically able to address in this context, but I think I just want to acknowledge that we think it's important. It comes up a lot within DSS about how we think about those things, acknowledging that this conversation doesn't necessarily address those directly in terms of getting those extra supports. But I think hear you, Karen, hear you, Ellen, that those are instrumental. And if we're referring to a waiting list, how is that really helping people? I think it's a very valid and good point.
Yeah, no, totally agree. I think screening referral is complementary to the delivery. And if one part of the stool is the leg is wobbly, it decreases the value in doing the first one. And the only reason why I'm drawing boundaries is I know just realistically, we need to draw boundaries. Otherwise, this group will expand our scope and frankly, our budget as well. I hear what you're saying. And I think the way that maybe I might propose that we fold that in when we're thinking about both the value and how we do the screening. I think we need to be realistic about the state of the safety net outside of it and take that into account when we're thinking about the payment and the structure.
Yeah, I have a practical suggestion around that. Sorry, Ellen.
Well, just because we're gonna start putting it aside, you're
Yeah.
trying really hard to
I
put
am.
it aside.
Yeah.
And I'm worried that we're gonna come up with something that was poor, crazed, overwhelmed primary care providers and let's throw some money at them. And like even screen and refer, which is just ask a question, which my primary care provider asks me lots of annoying questions and doesn't get paid, $5 per person to do it. If we're gonna do that, that's $60 million. That's already decided. And it's $60 million we can't spend on something else.
Yep.
So I know you say things at the beginning that overrides everything, but it kind of doesn't, and we forget about it. So I think every penny here, we have to think is a penny we're not spending on those kinds of supports that we know are a problem.
That makes sense.
If I can comment. So I think the point is really well taken that these platforms that electronicize referrals, et cetera, are great, but often, puts an undue burden on the organizations that are actually delivering services to these members. I always say healthcare is not going to solve poverty and structural racism. I think the real solution is community reinvestment. And where does that money come from? Is it going to come from the state? So if you look at the Aunt Berthas and the Unite Us these are funded by venture capitalists, right? So I've seen communities go back and say to the United Us of the world, so we're going to use your platform. We're going to put all this undue burden on all our community organizations. Give us back some money. So there's an opportunity for value-based contracting, even with these, venture capital-based platforms. So just a thought. It's completely separate than what we're doing here today, but I've heard a lot of talk about this on the national stage.
I just want to recognize, I think CJ, I think your hand's been up for a while. Oh, no.
Alice was before me.
Oh, I'm sorry. It's the screen is cut off. I can't see your hand,
I know,
Alice.
it's a little
No
hard-
problem.
It's hard to not have the DSS hosts picture too. CJ, you go first because I love hearing what you have to say, and then I'll chime in.
I hear you. So I want to second what Ellen just shared because it is true. It seems like the burden is passed on to the nonprofits and they have to figure out on the fly how to make this work. Let me give you an insight into that. When you do that, you are forcing decision makers at these nonprofits to make some real hard decisions on their staff. They have to revise their workflows, they have to train their staff, and then they have to deal with what that comes with because you just added a strain that really, as Ellen suggested, if we reviewed this differently. Now, while I appreciate the data shared, that's fantastic, but I'm from the islands, and what we say in my little country that looks like a Timberland boot, don't wet your neighbor yard before you wet your own, okay? So I'm gonna ask DSS to consider a thought. How can we support those who are supporting us? The other thing that I'd like to comment on is the intake questionnaires. I have had many people, and it's still happening, who are not getting the care that they deserve. They are not going to doctors. They're sick. People are literally not going to the doctor for anything mentally, health-wise related. Why? You know how long the intake takes? And it's frustrating because, again, going back to what I just said, folks are going into these offices, then they have to sit, they get called up, they're like, oh, finally, I get to see somebody. Oh, wait, before we see you, answer these 50 questions real quick. I mean, what are we doing here? Really, right? And where is that really getting us? We're not solving anything. We're creating processes within processes. And while that's happening, guess who's dealing with the stress of that? That's all I have to say. Thank you.
Thank you, CJ. As always, it's hard to follow you. I just want to, and I think I might have missed the December 7th meeting. So I'm a little surprised about this screening and referral. I guess for me, I feel very strongly that from the experience of what we've had in multiple settings, that if we really are going to target case management, chronic conditions of our individuals, that a screening and a referral is not the way it works. It does, we are a referral agency and we understand that a lot of the folks who are high cost, who don't make it, for any prevention or the things that they're supposed to happen until they're actually quite ill, really need someone to navigate for them. And so building in a model for primary care that has an engagement of either community health workers or care coordinators, we're building this intensive care coordination model from a public health bit, but we have been doing this in the schools. We have clinicians, of course, that are embedded, but doing care coordination for families in the school. You need to have a person helping you navigate these very complex systems. Some only need a little bit and some need months of support. And so if there is going to be money put into primary care, and I feel very strongly that to reach our families, you need to be in the primary care and you need to be in the schools, period. You know, like, that's where we should be and that's what we should be doing, you know, completely. So, you know, I would suggest that as you go through the financing to embed, not embed clinicians as much as embedding care coordinators into the primary care that can go into the home, can work with the family, can leave the office and engage, you know, helping families navigate, individuals navigate. Thank you.
CJ, is your hand up from before?
Yes,
or is
yes, it is.
Yeah.
No, it is. I just want to follow up with that. Thank you, Alice, for pointing that out. And I just want to note what's being said in the chat, right? Because we're not solving the problem, we're passing the burden. Because the part of the issue is these grants and fundings are written, but they're not taking into account the support staff. Your support staff is your front line. When your front line is not functional, guess what else breaks? So now you have leadership having to mend the front while manage a whole agency. And guess what the state wants? Data. I can't give you what you want if I don't have the people there to do it. So let's think about that, right? We want to solve the problem, but let's put this word in the mix, efficiency. And I just want to take note, folks, if you can, please read the comments in the chat because they are quite significant. And I hope Angela could jump on, Angela Phillips, and share a couple of thoughts.
We welcome that. Angela, if you want to weigh in. Yeah, Angela's in the chat. Angela, are you able to comment?
Yes, I was trying to type as well, so forgive me, because when you transfer over to use your mic, you lose your chat, so apology. Want to just lift up the concept when you're looking at data infrastructure and data sharing, that we don't forget patient access. Right now, many practitioners, specialists are branching away from the use of MyChart, Epic, some of the global systems, requiring patients to now have to have multiple logins to see their own health records, which kind of is counter the whole Affordable Care Act visibility to health records, goal. But having to have access to multiple systems is burdensome and just creates another barrier. Also, if folks are using advocates, community health workers, have visiting nurses, therapists who traditionally don't have access to these systems, at least the patient can give them visibility when they're in their homes or meeting with them, so that they can communicate with doctors, see, medical reports, test results, to actually make their time with the patient more effective and give them the ability to assist at a higher level. Thank you.
Essentially, just want to say, I think partially, just to be responsive a little bit, is to say, I think as part of some of these, team-based care, coming back to having non-clinical staff, definitely part of the conversation. I think, how do we think about community health workers? How do we think about non-clinical staff? And I think, Angela, to some of your points about how do we make sure the patient care experience or the person experience is front and center, is I think partially related to how we build that model and we build it moving forward, so we make sure that that voice is captured and heard in some meaningful way. And if we tie that to incentives, possibly how we talk about payment, I think that some of that is, it's not Shangri-La going to fix everything. I think there's significant challenges through this process, making sure that those community-based resources are resourced, so to speak. And I know that's been said multiple times, and I think just want to acknowledge that, and that we hear that screening referral doesn't fix what's happening outside of those walls, but maybe there's some opportunity to think about creative solutions. But this process today is really trying to think about how we pay primary care differently to maybe change that care experience. Angela, that I think you and CJ, you somewhat highlighted that maybe isn't always as person or patient centered. And as someone who's been a primary care provider, I definitely have seen that in how our systems are built and designed, often around how providers are paid. that often drive those clinical work streams. And I think it is very much related to the conversation. It's like how we pay providers can definitely affect the experience that people have.
Process. And do you want to try?
I just want to maybe go where you're going. I think everybody's making really good points. It seems to me like there's a supply issue, just access to advanced primary care kind of isn't adequate. And if we don't pay people differently, kind of we're going to continue to have the whole problem. So I think, again, kind of everybody's points are good, but we need to start diving into the payment.
Yeah, I was gonna make a quick process point, and I'm glad I summarized, because sometimes when you summarize, a group can reassess, and I think that's really healthy. It feels like there is not, although we covered this earlier, and there was consensus on it, it's really there's not consensus on that, which is fine. People with the fullness of time, your opinion sometimes changes. I wonder, process-wise, I wonder if we can put a pin on, and I'm looking a little bit to Brad and Olivia, because maybe this won't work, but I wonder if we can revisit the health-related social needs question about what scope we want to be on in our next meeting. I do want to get to the payment stuff, because I think it's really helpful to talk through that together in a group in one chunk. But I don't want to push this thing down. I'm wondering maybe if in our next we can revisit that in our next meeting.
I think so. And also at the end, we built time into like, what else are we missing? And so I think we built that question in, Commissioner, as you said.
I really do think that there's an important distinction here. And that distinction, particularly around the screening, is to create a payment model that creates that capacity. I think there is a distinction between having the capacity to engage in the screening and the tools that we'll need to actually engage in the screening itself. So ideally, we would be able to do both, but without a model that at least gives providers the option of whether or not they want to engage in the screening and pays them for it, I think that it would really miss a really important point. So that is really, in all of the discussions that we've had, this is the way in which I interpret this particular issue, which is that we're not saying we're not going to do it. We're saying that for providers that have the capacity to do it, they need to be compensated for it. And we want to build a model that allows them to do that. The larger infrastructure questions about what happens when a referral actually occurs, I think to your point is an excellent one. And that is something, quite frankly, that the state in and of itself cannot solve on its own. That requires a much larger investment of many other individuals, venture capitalists, other kinds of private and community partnerships to make that work. So I just want to be realistic about what I think that we can do. But I think to create a model that doesn't even give a provider an option to do that is a problem. So that's why that's just really what I'm going to say right now. Okay.
You get your hands up too.
Yes, I agree with what was just said, but also I just want to reiterate, when we're thinking about quality of care, passing on costs, they do meet, they do intersect. Let's not forget that. Let's not just talk about it and talk around it. We have people who are not getting the quality of care that they should be, or even considering to, because we have these barriers based on the data we're trying to collect. But we're not thinking about functionality. And as Angela is saying in the chat, functionality and payment method / cost are equally important. And I agree with that.
And I think we agree with that too. What I am raising is that there are limitations within which a payment model in and of itself, whether it's a singular model or a multiple model, or it's a hybrid model, or it's different models depending where we're going, can actually address that to the level that I think we would all want to see happen ideally. But I do believe very strongly we need to start somewhere. I think we can all agree that the manner in which we are now paying providers needs improvement. That's why we've been at this for the last 8 to 9 months. So I am really just trying to set more realistic expectations about what we can accomplish in our current work, and also then create a path for us to address the really important issues that you're raising, because this will not solve everything. So we'll pay primary care providers based on our care delivery priorities that have been identified. But then we still won't have enough of community health workers. We won't have enough behavioral health capacity. We won't have enough pediatric capacity. And those may be chronic issues that we'll have to continue to chip away at. But that doesn't necessarily mean that we're not acutely aware of them and continue to work on a path to solve them. So I just want to be sure that those continue to be raised up, but that we're realistic about what we can accomplish with the task that's in front of us. That's all I'm saying, CJ. It's not exclusive and it's not mutually exclusive.
No,
It's-
you're absolutely right. I agree with you.
Okay.
And I want people to understand that too, because part of the issue here is that we have all these hands in the pot, but only certain hands get certain things. And I think that's what's also affecting it. So you're absolutely right. It's not just one entity here. This needs to be a group effort. And some of us need to agree to disagree to make it more for what we say we're about.
Understood.
You know, your hand up. I don't know if you want to-
Your hand was up.
You go first.
No,
That's just a request.
well, go with your request then. Go ahead.
I just want, so I'm relatively new. I know you said you've been at this for 9 months and I took the place of Michelle Mullins on this committee, but and if this has already occurred, but my request and recommendation would be to consider whether we take a step back, talk about structural racism and how it impacts access to healthcare, so that we can be sure that what we are going to be building is an equitable system. Because I think we're talking about a lot of things that in general, and it's one, you know, one size fits all, and it doesn't. And of course, I'm very passionate about the communities that we serve and to make sure that they're gonna have access to care. So a lot of what we're talking about isn't gonna get it done. And so that's why I would like to take a step back and say, can we talk about what structural racism is, how it's impacting access to healthcare? Because I think we might be making different decisions. It's just a recommendation and that's what.
No, and I do appreciate that. I think what I will say is, and I say this from the very unique space that I sit in every single day, that I have been pressing very hard, and Guy and Bill will tell you this, and so we'll hold that as we've been having these discussions, we have been talking about structural racism, right? The way that really the bias with which even I experience healthcare, right? I've had the same provider for a long time, but when I switch providers and I just walk in the door in my sweats and my hoodie, right? There's a very different experience that I have when I show up and I have my little commissioner badge on, right? And I know where that comes from. So I would have to say that I think you're absolutely right. But as we've been building this, I've also been pressing, and we just had this discussion about, well, what happens in a rural community? What happens in a different community that has a different demographic? What happens in New Britain versus what happens in Shelton? Should we really be thinking about how we build our models so that we can understand that when a person walks in the door and a person is of color or a person is poor or they're both of those things, or a person is homeless. So I think I'm thinking about it in a much larger context than structural racism. I also think that there can be a fair amount of discrimination that happens based on your socioeconomic status. I think it can happen based on where you live. I think it can happen when providers make assumptions about your educational level. All of those things, right? Impact the quality of care that you get, the way that you are treated, and the assumptions that are made about who you are as a human being when you walk in the door. So what I'm saying now is, as we're walking through these payment models, to trust to a certain extent that we've had these really difficult discussions internally about what they should look like. And if we can continue to have that here as we walk through these, then, and if you don't see that reflected, then we can continue to have those discussions. But I wanted to assure you that those discussions have been had.
Thank you. I appreciate that.
All right. I just add, Commissioner Effie, just to say that as we're talking about these payment, is like that lens of equity should be in mind as we're talking about payment, because payment can affect the equity outcomes of the people that are being served. And we also have a upcoming meeting where we've tried to weave some equity considerations, including on racism, people's access for individuals with disability, other, et cetera, that we'll need to come back to and make sure that as our directional guidance to date includes these considerations that are really important. Understanding it's going to be hard for us to address everything, but can we take a meaningful step forward as we think about payment and these decisions that we say, we do think we were really very intentional about keeping equity at the center of making some of these decisions. And I hope we can say yes at the end of this. So with that, if it's, and Tiffany, do you?
Yeah, I know that we are putting a pin in the health-related social needs screening. And for our next conversation, I really implore us to think about who should be paying beyond DSS. We have community benefit dollars that should be going back into community. We have state dollars that need to be funded at a more global way. There are mechanisms and payment models in which primary care, even with their savings, can reinvest back into community-based organizations. So what are the ways and the structures in which that we can consider the reinvestment back into community-based organizations needs to be a broader conversation.
So Tiffany, I would agree with you, and I will say without getting my appropriations chairs in trouble, that we have been talking to them about a more global approach to healthcare in general. One of which is looking at rates, the other of which is where are we spending money now that perhaps we need to think differently about where and how we're spending it. What else should we be bringing to the table about the ways to have discussions about the ways in which we are spending dollars so we can get better healthcare outcomes. So those discussions are happening, and I would be more than happy to have them again here, because I think this is an extremely important audience to weigh in on that. Yes.
It just also makes me wonder, so there are parallel conversations taking place via the comptroller's office with the transformation conversations. And while they haven't provided their final recommendations yet, I understand that some of this exact conversation is taking place about blending and braiding, about other entities. And when I think of pediatric care, the impact that we have on children has an impact on the healthcare system, the education system, the juvenile justice system, et cetera. And I think there are opportunities. I do hope that our conversation in this room has some connection to the conversations that are taking place in other rooms, because I think therein lies some of the opportunity for cross-department, cross-division funding to improve health, not just healthcare.
I can assure you, I'm co-chair of the Children's Health Committee, and the same recommendations are being made, actually, they've been made around funding and bringing care coordination in and placing them in places like primary care and in schools. So that is definitely one of the recommendations. I'd be happy to share what our recommendations are with you so you can at least have them. And I also think there's an opportunity with the state plan to pilot some of these opportunities, right? That's what we were recommending to the comptroller, because you know he's in charge of the state health fund, which is a lot of money that they spend, and so why wouldn't we do that with some of those dollars? So
I think for purpose of time, we're gonna keep, obviously, I think, put a pin on a little bit of this and try to make sure that at the end, there's a little time just to make sure that we identify other things that haven't been discussed, and also make sure we're bringing back some of this conversation for the future.
Brad, I'm sorry, just one more.
Yes.
Olivia, were you trying to intervene in some way just now? Okay. So I think I'd like to do a little bit more than just put a pin in it. I think I want to make a commitment that internally we'll have the discussion. I want to connect with the controller's office again, and really the next time that we meet, I think come back with some just points of clear discussion about the screening, right? And ways in which we can really start to even just think about how this might work in conjunction with our payment model. Because we don't want to, screen and refer into an abyss. That's the right, and that's what I'm hearing, and this is what happens. We might not be able to solve it, but I think we should at least prepare ourselves for a more substantive discussion about what some options might be.
And that totally makes sense. I think makes sense. I think along with what you said, that we should have a follow-up conversation. So now we're just going to walk through some examples to kind of level set in terms of terminology for payment models before we jump into that conversation. And so we've broken this down into using a framework through the Urban Institute typology of payment methods. Some may be familiar with, some may not be, but thinking about this from the base payment rate. So with how the majority of dollars flow to providers, calling that the base payment. Typically, that's going to be on the right-hand side is in the blue fee for service, a hybrid between fee for service and population-based payment. That's historically also been referred to as capitation, usually a PMPM or per member per month payment. And so that's kind of the base payment, how most of the funds are flowing. Underneath that, you'll see incremental payments. We're also going to be calling that performance-based payments today. And those can be smaller incremental payments that are combined with rewards, penalties, or additional payments for specific purposes. That can be non-visit functions such as for care coordination. And then there's also performance-based payments, usually based on an outcome of the nature that you get rewarded or penalized on. And there's shared savings, shared risk, which is usually based off of a total spend around the specific population. So we'll dive into the details on the next slide. So we're providing a little bit of definition here in terms of what these mean, and I think it's helpful to go through them.
Can I just say, so the next 5 minutes, 10 minutes, I want to just have a primer, because I think people are coming to this conversation from different places and different expertise, and everyone brings his or her own expertise, but we want to try to level the playing field so that we're having shared vocabulary. So this is gonna be a little bit more DSS speaking for just the next 5 minutes, and then we're open up for discussion. I just want to orient you why we're doing that, because if we go back to those 5 priorities and the ways of measuring them that we discussed in the last two meetings, the next question is how do we encourage and incentivize it? And Brad's gonna outline some options, at least some shared vocabulary. So anyway, that's just the orientation. So 5-minute seminar. Thanks.
All right, here we go. And so fee for service.
Please interrupt with questions too. I just wanted to give context. Right now, we're not endorsing, we're just giving vocabulary for then the discussion we'll have.
So fee for service, so a payment approach in which a specific amount is paid when a particular service is delivered. So usually this is, again, we think about something, you do something, you get paid for it as a provider. That's kind of the very high level simplified version of that. I'm going to skip hybrid fee for service, PVP, which is again on the top, again, talking about base payment. I'm going to go down to population-based payment and just walk through that, and then we'll go back to the hybrid. So hybrid population-based payment, or PVP here, again, historically been referred to as capitated payment. So that's a fixed prospective payment made to cover the cost of care for a defined population over a specified time period. Usually, again, it's often abbreviated as PMPM, or per member per month. So it's based on the number of people that are being cared for under that provider. And it can be paid off of month, but it can be paid off of year or quarter. There's other ways of doing that. And then there's a hybrid between fee for service, again, where you're being paid based off of doing something, and you get paid for every something you do, versus that population-based payment is paid for the person for a defined set of services that you're paid on a recurring basis. And a hybrid is basically where you just match those two things together. Usually you'll get some of the provider will be paid some fee for service, and can also get some population-based payment, or PMPM. The next one down in the green is incremental payments. Also, we'll be talking about mostly based off performance. We're gonna in our conversation, we'll focus on pay for performance and shared savings, shared risk, but we'll start with non-visit function payment, what that is. And it really simply is a model where usually in a per member per month fashion, people get paid for non-visit functions. So that can be care coordination. We do this in our existing PCMH Plus program, which we'll mention later. So this is usually layered on top of, incremental payments are layered on top of the base payments. Again, I'm the provider, most of the revenue will say over 50% is coming in through this base payment, and then these incremental payments, which can be non-visit functions, add on top of that. Pay for performance is a payment model that includes financial incentives based on ability or inability of the provider to meet certain performance standards. So it might be a quality measure, like you lowered A1C for your population by specified. It can also be based off of utilization of services. It can also be based off of cost, potentially. There's many ways of doing pay for performance. Shared savings, shared risk. This is a form of payment in which a provider or organization shares generated savings with a payer when actual spending for a population is less than a target amount. So there's a target amount of spending, it's called $1 million. If there's shared saving with the provider, you might say we're going to split 50% of the savings based off of that target of $1 million. So let's say it's 900,000. So if he's DSS and I'm the provider and we had a target of $1 million and the spending comes in 900,000, that if there's a 50-50 savings, I would get a $50,000 and DSS would retain, as V would retain $50,000 in a simplified way. There's shared risk as well. And so also known as upside and downside. So upside is when providers can retain those dollars and only make money when there's savings. Downside is when there's actual risk. So if you had $1 million target and it actually the spending comes in at $1.1 million and there's 50% downside risk, that provider actually, I might have to pay DSS $50,000 if that's the case. So just to give an example of what that means. And so sometimes you only will set upside only, which is what we have in our existing PCMH platform, where you can only make upside even if there's potential overspending more than the target amount. So let me just pause to see if there's any questions about this. We'll be talking about these terms more, but I think just to kind of, again, as Guy said, we're trying to just level set as to some of the terms, what we'll be talking about today. And I know many of you are very familiar with this, some of you may not have heard of this at all. Now we can, oh, sorry, go ahead, Mark.
Quick question. In this context for today's conversation, is population-based payment and it's essentially equivalent to primary care capitation, or in population-based payment, are you contemplating a payment that would extend beyond the services of primary care to include hospital, pharmacy, and that sort of thing, just to make sure that the usage is understood?
For today, we really were considering this just for the primary care portion of the payment, as opposed to things outside of it. Might be difficult for us to extend it, but I mean, we could be open to, I think.
I wasn't proposing it, I just wanted to make sure.
It creates a lot of complications to do it, as you know, I think. Marky, you might.
The only thing I was gonna hop in, just going back to the discussion we had last time, the performance measures. One of the performance measures we all identified very rightly across multiple of those 5 domains was, for example, preventable ED and preventable hospitalization visits. Marty, just clarifying your question, I very much would think of those things as being in a pay for performance, where we would want to encourage providers, behavioral health, chronic disease management, helping prevent hospitalizations. And I think that would be very much in scope for how we potentially think about paying primary care. I don't think, Brad, I'm saying anything different than you. I'm just clarifying that something, a hospitalization is technically not primary care, but it's at least partially under the control of a primary care doctor. And I would want us to have that potentially be in scope for today's discussion.
Just a quick, we dealt with this a lot. You look at some of those chronic conditions, they fall very much on specialists. Primary care is not managing complex heart failure for the most part. And so to tag them that they are performing, they have to control that. When all those people are seeing specialists, you get a disconnect. So we just got to be thoughtful about, I agree that those utilization metrics become important, but it's what do those clinicians actually control and what don't they control? Because to task them to do something that they're really not controlling is not going to get us where we want to go.
And I think just to clarify, Mark, you were just saying on the population-based payment specifically, like usually you define that within the scope of what primary care services are delivered historically. So it typically doesn't includes, the full circle of spending. If you say includes hospitals and other things, usually you're carving out this population-based payment just for those primary care services and not including things like general pharmacy expecting the primary care provider to also manage that. And I think you were alluding to,
That's what I figured where you were headed, but based on discussions we had with members, there was confusion when we were using terminology, and I just wanted to make just a little set.
Yeah, and that's a great point of clarification. Thank you. Alice, please.
Yeah, I was wondering, was there any discussion about doing anticipatory tiering of need? I know that you're going to do some screening, but what we're doing in INC is really taking the population and looking at certain criteria and then tiering them. But the final tier is sort of established through an interview. We call it a health journey with the family, with the individual, to see what's going on with the child, so that then a primary care practice may have X amount of tier 2, tier 3, and then do a PMPM based on that role. But I just wondered if there was any, instead of post reward, if you will, by saving or whatever, but having a clear definition of what the population is that the primary care person is taking care of.
think a little bit, talking about some maybe risk adjustment or tiering people in terms of that, and that would definitely will come up as I think as part of the conversation that we're having. If I'm hearing you correct, Alice, in terms of making sure you're having people with different members or patients would fall into different tiers based off of risk and other needs. And that
And the
definitely, I think,
payment could be associated with because the depth of need that might be for tier 3, where, you know, if a person may need to go to cardiac care specialist, but they're not getting there, you know, for all the different reasons that they're not doing. And how do we help them manage getting there and all of the complications around that, allow for a person to get the services that they really need.
yeah, definitely a great point. And I think it definitely falls within today's conversation in terms of how we think about structuring some of these and what you would need to do to make this work for different populations and also different providers.
And I think it's essential. I mean, depending on what measures we pick and priorities from last discussion, I think being sensitive to the denominator, what's included, and then also how you adjust is an essential part of making sure that we don't inadvertently reward or punish providers for treating healthy or sick or people with disability. I think this is Alice, your point is it's essential, I think, to any functioning well.
And I just want to say we're doing it already. The DSS is doing it already. We've already set up the whole tiering with CHN and Carillon and DCF and all of those things. So it's already done. It's not, doesn't have to be recreated.
Just, I'm not sure this is a question, it's probably a comment. But I think we need to think about, when you talk about, to Mark's question of whether this is just about primary care or the larger health system, more and more primary care providers are working in a large health system. And once, I'm not a primary care provider, but I think saying that they're even partially responsible for hospitalizations would make blood pressure go up because of all the things we talked about, social determinants, but also once somebody's in the hospital, you don't really control anything. And that just adds a lot of uncertainty and anxiety around those kinds of models that I think are important. The other piece we need to think about is, Paul probably meant it very differently than I'm going to say it, but I think the payment models have a lot to do with capacity and how many people stay in primary care and practice in primary care. And that uncertainty is going to make, nobody's required to take Medicaid. And we lost a lot of doctors when we moved to capitated managed care under Husky. And I'm really worried about that happening again. We have an enviable, among other states, level of primary care access. And I would not want to do anything that could place that at risk. And so I think making sure that, I mean, even if it's just upside risk, you know, we heard in PCMH Plus that, you know, CCMC felt that they were doing a really good job in terms of reducing preventable hospitalizations and ED visits. And they generated a lot of savings, but those savings went to somebody else. Even though they didn't lose anything, they had to invest to do that. So they lost something. And if we want them to invest, that they have to feel that this is, you know, they're comfortable going into it. And even with upside shared savings, I think we have to really think about the capacity issue. If we care about access, and to CJ's point, people not being able to get appointments, we have to make sure we don't lose anybody. This is Medicaid. We can't lose anybody.
I'll just say, if it's okay, just to make sure we get to that conversation, because I think that's definitely, great. I think definitely want to hear that, and it's definitely part of, I think, the good discussion we want to have today, and just want to make sure that we are all on the same kind of starting point before we maybe delve into, if that makes sense, if that's okay with everyone.
Makes sense. I know, Brad, you and Guy and I and Dr. Mahul, we talked about this, that these are the current existing models that we're presenting that are being used across other states. But there's always an opportunity for us to be innovative and different. You know, so I just want to be sure, and I want to assure everyone that we're presenting these based on the data that's available to us and models that are using. If Ellen, for example, we think, you know what, maybe we need to do something different, or to Alice's point that we need to really build in the tiers, then today's discussion, and I imagine subsequent discussions, give us the flexibility to have those kinds of decisions to make those kinds of decisions collectively about what we
Love
really.
it. So we don't have to live in these boxes. I like
We do
having
not
them.
have to live in the
Not
box.
good in boxes.
I'm not either. So it's okay. We don't, but we thought at least it provides a framework for our existing models that may be helpful to us as we're building. We can sort of braid it and blend it and, think about different ways you might want to do, to your point, that we are in an enviable state in certain regards.
I think the next slide kind of just shows that these aren't, you don't just pick one, that you can do multiple at the same time. And I think just to highlight that quickly, that you'll see again, kind of same framework base at the top in blue, incremental, and then across you'll see these other Medicaid models in the first section, there's 4 there, and then CMMI models, again, Center for Medicaid Innovation models. And you'll see even in the Connecticut existing models, Connecticut PCMH and PCMH Plus, our models currently, we have base fee for service payments. And then in PCMH, we have a pay for performance model. And then under PCMH, we have a non-visit function for FQHCs. They get paid a PMPM for care management services, as well as a upside only shared savings. You'll see some of our other states, so Massachusetts has a primary care ACO model where they've just moved to a population-based payment, a PMPM for their primary care services. And then they also have some different tiers, which we'll talk about later, but they have non-visit function payments. They have a pay for performance as well as shared savings and shared risk. When we put risk, it means both. You would almost never have just risk for providers. That make a lot of sense. When we put risk, it means they have upside and downside. Again, upside meaning you can make dollars, downside meaning you're at risk for losing dollars if you're not meeting certain targets. Colorado's APM2 has a hybrid fee for service population-based payment. So some of the payments are made fee for service, some are population-based. And then they also have a shared savings model. And you'll see under CMMI, I'll just note, you'll see CPC Plus, that's Comprehensive Primary Care Plus, PCF Primary Care First, and then CP is Making Care Primary. That some of them have different tracks or tiers where they use multiple payment methodologies. I don't think we get to the details on this slide. We will a little bit later, actually. But just to note, again, you pair these often together because there's upside and downsides to all of them, and you're trying to build something that actually is trying to achieve the goals that you're hoping to.
Tiering and tracking, just Karen, that's a allusion to, I think, some of the things you brought up earlier about, and as well, the comment about capacity, linking that all together, that fits into this.
This is just a little bit more detail. Oh, sorry.
Just about how many members are in either PCMH and PCMH Plus in Connecticut?
Total, I think it's about 600,000.
Like, how about it individually, are they?
Which one has
like
more?
PCMH?
PCMH has more.
It says it's about 55% of members are in a PCMH recognized practice and about 18% of members are in a PCMH Plus practice. So PCMH Plus is much smaller than PCMH.
Last count, it was 160,000 under PCMH Plus.
Okay.
For the record, PCMH Plus has been closed to new entries for some time period, so
yes,
it's probably not accurate to analyze the potential opportunity of 18% when PSS has not opened it up to numerous organizations for several years.
If I can, and I don't know if this is a friendly amendment or not to the slide before, if we could just add in parentheses FQHC only in the non-visit functions, I think that's important to point out. Apropos the point made about, I assume you were referring to private practitioners leaving Medicaid. The upfront payment that FQHCs get is not something that the advanced networks get. And that investment in community health workers, et cetera, is supported for the FQHCs, not for the advanced network. And I think that's really important when we consider this. When do these payments take place for the private practitioners especially? So if you wouldn't mind, just so people understand that, I think it's really important to point that out.
Just a note in the DSS, it says FQC is only in the non-visit functions on the incremental. Dave, that helps.
Oh, it's in the next slide. Okay.
We try to be more explicit. Sorry, Polly, go ahead.
Yeah, I think just building off of that, when I was, trying to distinguish between the non-visit functions and the performance-based payment, just, I think about the things that, are revenue streams and, based on attribution or whatever, like they come in on a regular cadence. Whereas the pay for performance and shared saving risk, you have to demonstrate a result. and the payment might come, months or years afterwards. So, from a provider standpoint, those can be a little bit tricky, and the blending of those can be really important because you need to make upfront investments and all the things we're talking about, care coordination, infrastructure, all of that. And then, you want to reap the rewards, but you have to have enough of this kind of funding mechanism to, support the infrastructure that you're investing in.
Yeah, I think great point, really important. And I think as we're thinking about what's next, those are really important to think about, like, well, what hasn't been as successful as we might want them to be in our existing models, or what's successful in other models, and how do we think about it, again, driving towards the overarching goals that we're setting. Just to highlight again that PCMH Plus has a PMPM, but it happens after it's a more of a, not a prospective payment in certain ways. Well, it's a per month, it's based on your quality scores historically, and then it's applied afterwards. So I think it's important to, what you're saying is, like, when do the dollars come to providers in terms of actually enabling some of the things?
Or if they come at all, too.
Yeah,
I mean, that's.
I think we can move to the next one just to kind of keep going, but I think we're going to be starting to jump back in. I think Ellen, on that shared savings, we have part 1 and part 2. Part 1 is focused on base payment. Part 2, we focus more on the incremental or performance-based payment, which I think you were bringing up around shared savings, which again, we bring that in. The first conversation is, how should DSS pay primary care providers to enable them to deliver care in a way that improves member health and well-being, and tries to focus on the care delivery priorities we have established.
I just want to jump in with a framing point, and this is actually linking several comments that we got before. The Commissioner's comment on what is feasible, realistic, the comments of the appropriations. So over the last several meetings, we've identified those 5 priorities and the things that we want to measure. I think it was a really helpful discussion. We collectively do not have unlimited resources. And maybe there's some flexibility to get more, but there are a lot of things that we would like to do and a lot of important priorities. And part of how I'm coming to this conversation, and like us all too, is thinking about trade-offs. Because we would like to be able to do everything, and Ellen, this is partly your point on, it would be nice to do X, but it costs a lot of money. What's the ROI that we're getting for it? So I just want to encourage us to think about feasibility and trade-offs, because if this group just says yes, 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 that ultimately is not helpful for getting a practical solution that we're going to be able to move forward in the legislature. So I want us to have that lens as we're coming to the money, because resourcing is not unlimited. That's all. Thank you.
And that goes for the practices too.
Yeah.
The resources are limited in the practices.
Completely. And we need to think about giving the resourcing to our provider partners for the things that we think are most important, recognizing that providers don't have unlimited resources on their end as well. So yeah, I completely agree. I probably preaching to the choir. The reason why I'm saying that is it can be nice to say yes to everything, but if we say yes to everything, we're kind of saying yes to nothing.
So the governor's established a target of spending 10% of healthcare spending on primary care. Is that your budget? Can you go to him and say, okay, Governor, here's 10%, kind of
weigh in on that
to the fire?
I'm gonna just add to that, because I just think we need context for what's the parameters. I mean, that's, I think what you're getting at.
So the answer to that question is yes, and I think the governor is certainly open to our coming to him and saying, you've stated very publicly that you want to spend 10% on primary care. Here's a model that spends 10% on primary care. And then depending on the state's fiscal circumstances, right, we need to stay under the spending cap, we need to look up, he may come back and say, all right, ideally, this is really great work. Realistically, I think I can do whatever X of that percentage is. So I think we need to be prepared to come to him with the ideal, and then something that's incremental below the ideal, so that at least we can get something that's close to our ideal implemented within, to Guy's point, within the term we use internally is available appropriations, right? That's really what we're looking for. But he is an individual that likes to ascend to the highest level of what we can accomplish, and then help us to kind of think realistically about where we can do that within what's available. So my sense is that we should be as, I don't know if these two things can go together, they feel contradictory in my head. That we should build what we think we need and then determine what we think is we can realistically employ based on our resources. That makes
Alice
sense.
had her hand up.
Could I ask a question?
Alice, and then, I'm sorry.
Commissioner, thank you for what you just said. I think that is
Okay.
definitely the right way to think. I think if we start, you know, we had an advocacy group many years ago where we were saying, you know, we know that there's enough, we're just tired of getting the crumbs. And it was a really important point, because there are ways of things that are being spent, and there are dollars being are out there that could be sort of classified, if you will, into a new way of spending to be able to get the outcome you want. And I think that you know, if we start with the finance worry, we're already starting in an impoverished sort of way, as opposed to really then looking at seriously, what are the other areas that could be cross or intersected or braided or blended to be able to get us to where we need to go. So I don't see where those conversations are occurring. And you know, it's a dangerous conversation for a private provider, because you know, we're like, well, you're going to take that money away and put it somewhere else. But in reality, if we're all here to make sure that we address the, you know, life course of 14 years between New Haven and Westport, then we really do have to design the right thing and find ways to be able to integrate. Connecticut spends a lot of money, and it needs to be looked at very carefully, I think.
So since the topic was brought up, what is the percent of spend currently in primary care for the Medicaid population?
Last time was 8.
Almost 8. It was like 7.8, I think, Hannah.
Yeah, just around 8% of Medicaid.
So.
And it was
actually
the best amongst primary
cares.
It's the best.
Really important in that calculation. You could probably say what I'm about to say. Is that when you compare on Medicare, you compare for commercial, what Medicaid spends on hospitals is about 60 cents on the dollar per the latest OHS report. Specialists are paid, subspecialists before the new increase, about 57 cents on the dollar. That's all part of the denominator. So you can achieve 8% by reducing the denominator. So it's just something to bear in mind.
Do we have a per capita spend on primary care? So instead of the percentage, do we actually have because that would be the way to make the comparison mark. What's the per capita spend?
I can, yeah.
I understand your point. If the denominator is lower, primary care will seem higher, even though it's maybe relatively lower than other.
So I think what is, Guy, I don't know if you're gonna speak to this, but what I think is a useful sort of point of reference is when you add in on your slides, the primary care rate bump, which we have in Connecticut, and then we have a PCMH rate bump of 24%. Where does that put you, say, relative to Medicare reimbursement just for core services? That's an important sort of point of reference as you think about what you're building on.
I was just gonna say completely, I will quibble a little bit with the hospital numbers, but that'll be a topic for another day. But I agree with the broad that Mark raised. And on the comparisons to Medicare, I think that's really important. DSS is doing a comprehensive rate study. Phase 1 is including primary care. Brad, do you want to speak a little bit to that here?
Just to say that we're somewhere in the 92% interest for Medicare fee-for-service payments specifically. And I think it's just important also to keep in mind that when you compare to other models, that's only on our fee schedule. It doesn't include any other payments outside of that, which is, I think, it's just important to note. But it is actually pretty close to Medicare for primary care for fee-for-service payments only. You don't want anything else.
Yeah, no, in the context, the this is a great discussion. I'm really glad we're having this before we get into the details, because I think it's important to level set. The context I bring to that, and part of the reason why I think it was really helpful to have the previous slide on PCMH plus, is we are spending, at least relative to benchmarks, relative to other states, relative to Medicare, in primary care and housekeeping, we're funding it better than other portions of the program. I'm not saying we're funding it enough or too little, just descriptively, we're relative to the benchmark, we're funding it better. I think that means that, and Alice, I think this is a part of the point that you were making, but let me just bring it out a little bit. There are things, if you take the current pot of money, which is not incredibly thin, you know, there are things that we could do within the current pot of money, there are things that we could do with additional money. And I think that's helpful. And part of the reason why we want to center on what we're doing today is just to, everything is on the table, right? We don't need to be bound necessarily by what we're doing today. That money could, if we think there's a better, smarter way to deploy it, that's part of why we want, you're assembled here today to think about how we spend within the budget and also how we spend normally.
Another thing I might add is that one of the payment models, shared savings, somewhat helps with this at times with the financing. Obviously, it's a retrospective and there's downsides to using those models, and I know we'll get to that. But that can help with additional dollars when you're talking about reducing especially unnecessary spending, or even sometimes harmful spending in ways, because that can be potentially a way of adding extra dollars. Again, that's usually after the fact, but it is a way of potentially helping finance additional dollars to a system. So just want to point out, and I know we're going to get to that, but I just want to bring that into this part of the conversation because I know it's important as we talk about appropriated dollars or not. And Hannah, I think had.
Yeah, so I was able to pull up the per member per month spending for 2021 for primary care. It looks like the commercial market spent about $25 PMPM, and the Medicaid market spent about $27 PMPM.
I think we'll move into the base payment conversation. I know it's a really important one to talk about. And so just to say that and I think this has come up, Aaron and Timmy and others brought this up, is there's variation amongst providers already about both the starting place and also needs of the population that those providers are serving. And so some of the strategies that we'll need to discuss to think through this would be having tracks or tiers for different groups, developing glide paths, which we've done in the past, providing technical assistance, and investing in data infrastructure and data sharing. And so today we're going to really talk about design and implement a panel that enables broad-based participation. Again, very broadly, knowing that there's additional needs that some subpopulations may require in the future. So kind of starting this broad place today. Next slide. And so we're going to review the starting place, and through this relatively quickly so we can get to the conversation, and then we'll have this collective feedback. So next slide is strengths and limitations, just quickly on fee-for-service. So fee-for-service, and on the left side, you'll see strengths and limitations that provides a strong incentive to increase the volume of services. So it does have to pertain to access, so we discussed. It does not necessarily have to be risk adjusted, though it could. There's limitations of it. It can incentivize over service as well, which can be harmful. It provides little flexibility without it's currently designed to deliver non-visit or integrated non-clinical care. And again, it encourages high volume, which can lead to potentially shorter appointment times depending on how it's structured. Flexibility. Move to the far right on population-based payment. Again, historically we talked about as usually a PMPM or patient. This is usually the positives can provide more flexibility in care delivery, reduces imperative to generate office visits, and enables delivery of non-visit care, enables the use of different care modalities. Again, fee-for-service does this, but this can do it more flexibly, and provides more predictable revenue. It can incentivize patient empanelment attribution. But the downsides that it has to be implemented with guardrails. It can incentivize underservice as well. I think that's on the other hand of this. So you have to really be thoughtful about how you roll this out, because you need adequate risk adjustment to protect against what historically has been called lemon dropping, but it's really providers trying to not see individuals who may be high risk and who they're worried they wouldn't get enough dollars for. You don't have to worry about building a quality program as well because of stinting or underservice concerns. So those are really important considerations as well. And then hybrid is a mashup between those two. Then we go to the next slide. And just to say, I'm not going to spend a lot of time for getting to the conversation. say, you'll see that there's different tracks and options. So I'll just highlight Colorado's APM2, which is kind of in the middle there. They have a blended perspective population-based payment fee for service. They actually let practices decide. They slide up and down on that, what they want. You'll see on the CPC Plus, you'll see there's different tracks. One includes a fee for service, one is a blended prospective payment and fee for service. And then Making Care Primary, another, again, CMMI initiative, has different tracks again, where they go all the way from fee for service to a blended option and then to a prospective population-based payment. So let's go on to the next. And then we try to do an initial assessment based on the priorities that I identified and whether we thought, could these actually address some of these, could fee for service or a population-based payment help? And we actually pretty much checked all the boxes. Now, we didn't weigh them to say which one would be more effective or less. But we just wanted to say that, well, all of these might be able to drive chronic condition targeted care management. There's TCM fee for service codes. Could it drive accessibility? They both potentially could, depending on how they're structured. Health-related social needs screening, both of these could. We didn't, data infrastructure, we thought that incentivizing, that you could incentivize this probably more through performance-based payments than rather fee-for-service or PVP. And then team-based care also, again, fee-for-service can pay for defined clinicians historically. That could be expanded, even if it's more Medicare-driven. Population-based can support integration of those non-clinical with a little bit more flexibility at the provider level with who they're going to hire and how they're giving up those units. So this is just a starting place. We wanted to at least say, here's what we think might work. And now we want to open this up for conversation. So I think at this point, I'm going to pass it over to Dr. Dalal. And go to the next slide to start conversations.
Thanks, Brad. I'm happy to give Brad a break because you've been talking a lot, but also because then you can contribute to the discussion. Just on a programming note, we are 15 minutes away from our break. If we dive into discussion, I don't think we'll want to stop in the middle. So I just want to get a general sense with the head nods if people feel like they need a break now or are they just ready to dive in.
Okay.
Or yeah.
I'm always really conscious of the seat that I sit in. So I think it might make sense to take a break now and then come back and dive into the discussion.
Yeah, and that way you can take, it's gonna be important to understand that.
I have a point about these slides, the background and the shared understanding. Could I bring those up now?
We'll start with clarifying questions before we dive into discussion. If people have comments or clarifying.
Yes.
Or comments or whatever.
Yes.
We anticipate that. So again, so we'll say it's 10:24, so 10:34. We will plan on reconvening.
Okay.
All right, everyone, we're gonna get back together here for a second. Gotta go look at mine, absolutely. I would have done the same thing. And the same one. Turn it over here, I think, Dr. Mahal, the wall, but I was just combining your first and.
It's a portmanteau of my own name, which is that.
I think we'll turn over and then I go, I'm gonna start some framing conversation now. You're back.
Are we ready? Okay. All right, well, I know that break seemed too short. Appreciate the conversations we've had during the break. Actually, can I get just a confirmatory thumbs up from someone online just to make sure that we're being heard?
Absolutely. Yep.
Great. So our discussion here is about, again, just a quick recap. We divided discussion between base and incremental. Our discussion now is about the base payment. And we have a couple of questions. But before we do that, let's pause to see if there's comments or questions about just the previous slides that were shared. And I know, Ellen, you had something. I also want to make clear that, like, if you don't feel like you're understanding a concept here, and again, I don't want to assume everyone's at the same level, please chime in, either raise your hand or type it in the chat, and hopefully, Olivia, you're monitoring that and you can answer a quick question if there's some confusion about, wait, what is fee for service, hybrid population-based payment, and how does that mean it's a base payment? So please ask those questions, because we want everyone going with a shared understanding, as Kate mentioned. So Ellen, I'll have you ask your question.
I guess on the slide, base payment strengths and limitations, I don't know what number this is.
Yeah, can we pull it back up there? Thanks.
Under fee for service strengths, you have a strong incentive to increase the volume of services. But under population-based payments limitations, you say it must be implemented with guardrails. I would say that there's a strong incentive to underserve. Once a provider's got that money, in the bank, then they have to give it up to provide those services. And that's a disincentive. I think that's fair. Also, in terms of limitations of fee for service, normally I would agree that it gives an incentive to over service, but not if you believe, again, and I'm trying very hard to use a neutral statement here, but if you believe you're being underpaid, then there isn't, especially in primary care where they can fill their schedule very easily with more lucrative patients. So there is not necessarily an incentive to overserve. You don't keep people coming in. More often you're losing money on not that I endorse that, but losing money on everybody who comes through the door. And also I think the point, the alignment with priorities on health-related social needs screening and community supports, under population-based payment, it can support traditionally non-billable activities, but the provider again has to take the money that they've already got. There's good psychology about once you have it in your account, it's yours. You don't think of it as giving a student a mug and then asking them how much they pay for it, as opposed to before they get the mug, they value it more once they have it in their hand. So that is going to make it less likely to, they're going to have less of an incentive. They're going to have to overcome more resistance to spend some of that money on health-related social needs.
Thanks for those comments. I'm sure we're capturing those comments. Those are great.
Can I probe a little bit more in over service?
Sure.
So are we thinking about this in the context of asking for more tests, more referrals? I just want to make sure that I understand that.
Again, that matters whether you're an independent primary care provider or if you're part of a health system. And if you're in shared savings as opposed to an upside. And so that's a complicated thing to say. And also you get more visits on your entire panel. If you screen people more, you're going to get more visits, even though some of them will be negative. But you're going to generate more visits by doing more tests. So it could be coming back to you even in an independent practice.
Okay, that's helpful. Thank you.
I'm probably overthinking it, but.
The only thing I might add is depending on what services you're paying for, like in primary care, you may not be willing to see someone. You might not be willing to address something virtually or online unless you can book it for a visit because there's no payment for it. And so it can lead to overserves of things that you may not, you may not, for example, if you don't pay enough for a service, you still may get overservice in such a way, or it might not get served in a different way because there's not flexibility in that payment. So it can lead to a different type of underservice.
But again, that assumes that there is not a limited amount of time on your schedule. And so you could fill it with somebody who at a higher rate. Again, not for FQHCs, but for others.
I had two things. I asked Olivia during the break, just the number of practices that are in PCMH and PCMH plus, and it was about, kind of probably imperfect, but 98 in PCMH and 31 in PCMH plus.
And Dr. McGraw should confirm those numbers too.
I can check the dashboard, but not off the top of my head.
But proportionally, does that seem make sense, kind of that they're.
Old and imperfect, but I think the ratios, right, are.
Sounds about right.
And just because I sit in those meetings since like, the dawn of time, that it is going up for PCMH every time we get more, every quarter when we get reports. Also in PCMH plus is far more weighted toward FQHCs than non-FQHC practices.
Was it PCMH plus that was closed?
It is. So that's what I was just gonna say is that if that one's closed, then there's a potentially fixed number that can even service. So you're gonna have the growth on the other side.
I know Ben, I don't know if you saw that.
Oh, okay, yeah, go ahead. Ben from Stanford Health.
Hi, thanks so much. So the question we're asking is fee for service versus more of a pay for performance model. And I did ripped out the opportunities ahead page and I'm looking back at it, and our goals are number one and number two to address disparities in quality of care and ensure members have easy access and timely access to care. And we think that more primary care is a good thing, that more primary care to try to offset some of the unnecessary utilization on the acute side is a good thing. And we're in a world where, as great as it is that Medicaid is paying better here than in some other states, it still isn't paying as well as commercial insurance. I really think that fee for service is the right way to go, at least for the base payment.
Thank you. Alice is next.
Hi, so for a different point of view, Ellen and I have had this discussion many a time, and I understand. There's a couple things that come to mind around the practicality and also what are the assumptive bases we're making here, right? The first thing is the assumption is that the primary care doc will hire people to do this work so that they're not doing it themselves. My challenge would be for us to think, well, what if they actually partnered with a community provider, okay? And a community provider went out, was there located, and then was able to do the screening, and then actually then be able to expand and deliver or help the person coordinate. The next thing about that is then if the community provider is the person who is providing those services, it would be easier to determine a PMPM for that so that you could have a contract with the provider to say, okay, you have 10,000 folks that you need to serve. We think, you're gonna need X, Y, and Z in terms of services for those people, in terms of coordination. And then the PMPM would be more of a guaranteed payment for the collaborative process between a provider and the community. The other thing is that, again, if you're going with my assumption of, partnership as opposed to these docs hiring full-time staff to do that, because what happens is the staff get full, this is just what happens, right? And so if you have a community provider who has more flexibility, they might be able to, grow as they grow. The reality is that we need to make sure that we have a PMPM is a easier way to bill for our community providers than for a fee for service, because many of the people who are providing these kinds of services that people actually use and get help with are not medical providers, right? They're Christian Community Action, Project Access, all of those things, and they don't have a billing system. So being able to, create a model where they're able to do a CMAP bill and get, paid for that service is better. And it's also a guarantee of the hiring of the folks. I think we have to really, I know that some of the big healthcare systems have, care coordinators, or, I've said my daughter was in the hospital with diabetes incident, and she must have had 4 or 5, 6 different care coordinators talking to her. And maybe one called her after she left, but no one came to the house and no one ever has contacted her since. So, you really need to get a model that's going to work. It's going to work for our community and, be practical. And so that's my point. And so I would go for a PMPM, and it allows it more flexibility. Thank you.
Thank you, Alice. Those are some really great substantive points. I just want to acknowledge we've dove into substance. That's great. But if folks still have clarifying questions, feel free to ask them. Go ahead.
Thanks. I'm still, what I'm struggling with is we have a whole cadre of things that we've identified as priorities, and there's a lot to fix. So we all agree, and they were all really, really important, and you can, and we did some attempt to prioritize what we think is going to be that priority. We also have really one lever to pull. We've got a funding source that we're trying to figure out how to apply and bump that up against the priorities that we have. To me, where I'm struggling with is I don't know that we've really level set in terms of, for me, I'm going through, we got boundary conditions of how much money we're going to have, which is not well defined yet, but that's okay. What's going to be the biggest impact? What's the biggest thing that we could apply this incentive to do to make the biggest impact? What's the clarity of the objective? A little bit, is this going to be very prescriptive, or is it going to be freedom within a framework? We want a generalized goal, and we're going to let people decide how to get there, depending on the initiative we choose. And then lastly, how difficult it is to get it done, and can we measure it? Because if we can't measure it, we shouldn't be incentivizing it, because otherwise we're making it back. From that, we can then say, well, to get this, in order to get an attention, it's going to have to be this kind of funding, because giving people $3 is maybe not going to do anything for you. They're going to, as you said, put it in the bank and say, we'll figure out how to spend it, unless we're clear that this would get people's attention. But if it's access we have to do, we should focus on, okay, which of these things is going to drive access? Is it a PMPM or is it a fee for service increase? If it's totally going the other way, we need to really robustly build behavioral health. And we want to be very prescriptive about that as a first move, first status, first couple of years as this progress. That would build something very differently in terms of how you're going to think about both base payment and what you want to put in that incentives, and how much incentives we're going to need when we go back to the governor and say, this isn't going to be enough. It's just not going to get anybody's attention. If everybody has clarity on how we're doing all that, but I don't know, when we're already talking about the model, I don't know what we're trying to solve.
Hi, everyone. Not sure if you can hear me online, but we're unable to hear what's going on in the room. Okay, thanks.
Can the folks online hear us now?
Yes,
Yes.
we're good.
Sorry, we had a Zoom crash. Apologies, everyone. But we're back. I guess.
It was being very modest. It's hard to get attention.
I just want to add another kind of color commentary. I think what Jim has said is a little bit, I think what Ellen had said previously, and I think it might be helpful to describe a little bit of what the provider experience is right now with value-based care and the rest of the payer world. And it's a very different world than it was 10 years ago. Or 10 years ago, very little value-based care. Providers don't even understand what it is. And the landscape has changed dramatically now in 24, sorry. The majority of primary care providers are connected to an organization, either through employment or affiliation or membership, that are actively managing and participating in value-based care programs across the commercial Medicare Advantage and commercial Medicare space. And those programs have a wide variety of types to them, ranging from very simple participatory program with perhaps a PMPM payment all the way to full downside risk participation. And that spectrum is across the different payer types. And that spectrum is across the different organizations that do this. So we're entering this and we're bringing this proposal into a construct where there already is a fairly significant amount of infrastructure, fairly significant amount of commitment, a fairly significant amount of direction at those organizations. And I say that for two reasons. One is that we should consider what we propose in a context that we may have a more sophisticated provider base there than we have previously. We may have a provider base that is looking to partner in more complex models and complex approaches across the board. Now, that may not be uniform, and there may be a need for there to be variability. The second reason I bring it up is that, being somewhat late to the stage has a pro and a con. The pro is that a lot is already built out and is already developed, but the downside is that we've built out structures along a certain line. And so, not that ultimately that should define what we do here, but if what we do varies dramatically from what the kind of standard models are, it is going to be more challenging for providers to build up. And we will have less opportunity to take advantage of some of the economies of scale that may already be there, that are already in place. And so I just think we should think about that. We should understand that. I mean, enough provider groups here to give the group feedback as we go through that. And I would just to think through that there is this opportunity. The final point I'll make is that, and I think this is a frustration, you've heard my frustration about not being eligible to participate in the program, is we have, when the switch turns on for most of our organizations, no matter what we decide to do here, if we have a program, we have access, that there are services right now that would be provided to Medicaid patients if the switch was turned on, regardless of what your program is, that most organizations would begin to wrap those patients into our normal population health value-based care structures. And right now, our providers are actually desperate for data from us on the Medicaid population. Our organization is desperate to include those patients that see our providers into the already ongoing structures that are there in place as well. And so just a little background, and Jim's point is well taken. What is the goal is ultimately where we need to go, but just wanted to share that with the group.
Yeah, Joe, I completely agree, and that gets to the difficulty of implementing. There's things that some practices could really struggle with. There's others that have got a well-developed infrastructure that could layer it right in without really a lot of additional lift. And that's where we've got to just acknowledge that some variability, what I call freedom in a framework, allowing you to sort of pick and choose because people are at various levels of sophistication around this stuff. And we got to really acknowledge that, but that's an important part as to how we're going to figure out what are these choices that we have as we go down. So thanks, Joe. I appreciate it. I think I completely agree with you.
I just want to note that there's some comments coming in that I don't know if I haven't read them all, so I don't know if it's worth reiterating or, oh, Ben has his hand up. Okay. Sorry, I'll get you right after Ben.
Yeah, I just wanted to say, I completely agree that there are certainly practices across the country that are already in value-based or risk-based arrangements. I may have said country, I meant state, but I wouldn't say that it's well established, especially if we're talking about population or risk-based payments. I'm not familiar with the whole state, but I am very well familiar with Lower Fairfield County, and I'm not just speaking for Stanford Health. I'm thinking about the primary care physicians on our medical staff, and I would say, risk-based payments have not been something that, especially for smaller medical groups who already struggle to accept Medicaid, it would be a really big change for them to do some of the things that we're talking about, in addition to a payment model change.
Ellen, go ahead, because I have a question after. Yeah.
Sure, Mark also.
Okay.
But I guess my concern about that is I want it to be not a burden for providers, because if it's a burden, it's just not going to happen. But the way you do business for a commercial population is going to be different. The needs are going to be different. All the stuff we talked about social determinants, and also the payment levels are lower, possibly inadequate. He likes that. And so I think the incentives are going to be different. The needs are going to be different, and the way you address the needs are going to have to be different. So it's going to be a lot bigger than just, contracts. It's going to, and data systems. It's going to be, you're going to have to change how you practice. And it, translators, it's just, you really need to not underestimate. This is not just an add-on to what you're doing.
I agree.
Yeah, but I think also I agree with what you're saying, but all population health programs start somewhere, start small and build up. And I think one of the comments I'll make about the conversations that we're having is that, yes, there's complexity and there is work that needs to be done at the eventual goal we get to, but it has to start incrementally. It has to start with small steps, and it's built over time. So again, the experience in the market, and I acknowledge what Ben had said on the phone about groups that are not experienced, but the groups that are more experienced have been building this out over 10 to 11 years. And we didn't start with complex programs. We started with simple programs and built incrementally year over year over time. And so I think that I would encourage us to think about a long-term strategy of how we go through the glide path to get to a more complex program. But I don't think it has to be that on day one. I think there's value to our patients, there's value to the state if we start small and build up over time. And then I think there is more opportunity to take advantage of what's built out there. There's more in common between the Medicaid patients and non-Medicaid patients than there is different across the board. And we should take advantage of that infrastructure that's built in that can be transferred while we actually address the things that are obviously different for that population that needs special attention.
I was going to say, I love your enthusiasm to take Medicaid patients.
I'm here still, 10 years in, we're still going.
But I would be interested in understanding like the structure, for example, for the state employee plan that sees a variety of patients, some who may mirror some of the issues that we see in the Medicaid population, and some who may mirror more of commercial. I know that they've established some value-based programs. I'd be interested, this is just for my own edit, to understand how they've structured those programs to address the needs of a population that is very complex.
Yeah, I don't know the answer to that precisely. So as I can only speak to it anecdotally as an individual that engages in the program, and the engagement of I'll just call us the members of the state employee program is constant, right? There are navigators that are reaching out to you proactively. There's tons of email reminding you of all the things that you need to do. they'll tell you at a 6-month mark, at an 8-month mark, especially if you're enrolled in a particular program that incentivizes you to take care of your health proactively and charges you actually a lower cost sharing as a result of that. And then penalizes you if the people who are on your plan, and I know this from personal experience, don't adhere to, right? Don't adhere to the criteria. And so I guess we'd have to talk to a controller about the specific plan design, but from a user perspective, it is extraordinarily effective in getting people to be actively engaged in their care. And if that's something that we're thinking about, then I would say that we should explore it further.
Medicaid can't do incentives and penalties.
I'm sorry.
Medicaid can't do incentives and penalties.
Yeah, I know.
It's different.
Yeah, I was just.
There's another aspect
how
to
the
this too, though,
state plan works, yeah.
is payment reform and it's too bad Josh isn't here. And that, Polly, do you know, so the comptroller's office is kind of taken an advanced approach to primary care payment. I've heard a presentation from Josh at the cost growth benchmark meeting, but anybody familiar with it?
A little bit. We've had conversations with them.
We
They
have, yeah.
Coordination PMPM, and there's also some shared savings. I can't remember if they actually have.
Is that in alignment? I think that maybe that's what you all are saying, is that it would be good if there was some alignment between what Medicaid is doing and what the comptroller's office is doing.
Yeah.
I see that Mark has had his hand up.
Yeah, so I had a question for Joe, and I want to go back to the question, which is base payment and whether it's rely on fee for service. And I'm familiar with what the comptroller's office has set up, and especially at value-based insurance design features, which I think have been hugely successful, as the commissioner knows. And so the thing that, and I understand that there's cost accountability in the comptroller's model, and that there's additional payment for the extra things you do to support their patients. So the question I have for Joe and for Jim as well is, are all of even the contracts where you're in a risk sharing arrangement, are your practitioners, primary care practitioners, still being paid for fee for service for the core scope of primary care? And then ideally you've negotiated some, either a gain share or actually an upfront payment to support the additional capabilities. And if so, if that's the most sine tonic, your point is there are some things we can switch on that would enable us to extend the efforts we're doing here to the Medicaid population, recognizing that the Medicaid population has a lot of folks who have a lot of needs and barriers that are different than commercial. That's not universally true. And there are things you do that probably would have immediate value or benefit to the Medicaid patient. So it seems to me, just in terms of the question, just drawing a line from what Jim and Joe said, and the question that you've raised, it seems to me the shortest step to getting to the private practitioners who've mostly not, except for PCMH, been participating in your most advanced payment model into the game is to harmonize with the commercial and Medicare methodologies, which is core reimbursement for primary care fee for service. There's new capabilities over and above that have a certain cost associated with them. Maybe that could be a PMPM payment or something like that. Like there's all sorts of options here, but the question is that like just what we should do?
So to answer your question, yes, where we've got full risk in Medicare Advantage, and it's just based on a fee for service payment model for base pays for our clinicians, because that contracting has been done and it just simplifies. We have certain incentives built in to try and encourage the type of work that's necessary to actually manage the population more effectively, getting people in the office, blah, blah, blah. It's both access and the quality performance is the best way to think about where you're prospectively trying to get in front of that. And then a real opportunity around the overall performance of the plan. So you're wrestling down the utilization piece by saying there's a substantial opportunity gain sharing when you're performing well and taking out that unnecessary utilization. So that's the way that layers in. It's just the easiest place to go, and it's why Medicare Advantage is the place I think most people start to take risk, because it really simplifies things. It's an easy entry place. Commercial gets to your point, a very different kind of series of dynamics around it. There is no base really that you're starting with an awful lot of time. So that's the way that all works, and that's what we've been building the infrastructure to be able to come to. Joe?
Yeah.
Similar?
I think the state program, so the attractiveness of it was that the state chose to use one of the standard chassis that of a value-based program that was already in place with their third-party payer. So it was not a new program or new structure, very familiar to provider groups. And then they enhanced on top of that, which I think was the nice part about the model. And that enhancement was, I think, built around a stable base fee-for-service payment that stayed in place, and then putting in an augmented PMPM payment, which was designed to cover the extra services and extra resources necessary to support the population. And then the final step, I think they did that was important. They made the step though to design the program a little more specifically, so it was tailored specifically to the needs of the state employees, the state employee population patients, and then what the control's office wanted to accomplish with the population. So they took a standard chassis, augmented it, and then redesigned it to specifically tailor into that patient group. We've actually had relationships with other employers where we've done very similar things. We've taken standard models and augmented it for that. And then there is a component of upside and downside shared savings built into that program as well for providers. The other thing I'll add to, as I'm thinking about this as well, is that as we think about managing populations, one of the key fundamental principles of successful population health and value-based programs is this kind of stepwise process where you need to manage populations over time at varying degrees of risk and intensity so that you can understand the resources needed. So it would give you an example, it would be very challenging for anybody in their first year managing any new population to go into a more advanced model that had downside risk and more complex capabilities. In most of our programs, we manage populations over several years, and over that time frame, as we understand them and we understand the population, then we progress into more complex models more comfortably.
That's really helpful, that insights and this is exactly the type of, feedback that's really helpful for us. On a programming note, I'm gonna venture a guess we're not gonna get to topic 2.
No, that's okay.
And that's okay. All right, we can punt that because I feel like there's a lot of areas we can double click here and maybe different angles we can look at the base payment. That if we spend more time in that discussion, I think that'll be worth it. So we'll still leave 10, 15 minutes at the end for wrap up. So we didn't go in order, but that's fine. One of the things that we wanted to do is just to see these payment models in relationship with the priority areas that we discussed. So that's your slide 21 that you have, and our very quick kind of qualitative assessment on whether those capabilities lined up with the payment model that we're discussing, fee for service, population based, or hybrid. So maybe it's worth just walking through one of these and just thinking about the implications and perhaps nuances of each model. So with respect to chronic condition and targeted care management, I think.
Can I just say one quick thing?
Yeah, sure, go ahead.
Sorry for jumping, but I keep coming back to the comment you made maybe 15 minutes ago on what are our goals and the plan. I think that's a really, so I want to say just a couple of things. I think it's a really thoughtful question. And Commissioner, obviously, if you disagree, please, you're the decision maker.
Go ahead.
I think I want to be more ambitious with this than a single point solution. I think if we leave this having addressed just a single, as important as any one of these specific things is, I'm hoping that this redesign is going to be broader than just addressing a single one. Point number one I want to make. Point number two I want to make, I totally get your point that we need to think, what are we doing here before we figure out the plan. I will just remind everyone, not that we need to be bound by our past selves, but when we got these 5 priorities, they are in order based on the quantitative and qualitative feedback, based on the data that we're seeing. I don't feel bound by that necessarily, but I think the exercise Michael is about to do is very important, and I'm glad we're starting with number 1, number 2, number 3, number 4, number 5 in that order, just because that was bubbling up kind of where we thought. So Jim, what I'd like to take your comments is let's go through in order as Michael is about to, Dr. Wall is about to do, and let's think about the goals in the context of number one, number two, number three, number four, number five. And then at the end, then we'll need to synthesize and say, okay, they're all going in one direction and they're all going another way to the next. I don't know if does that sound right to folks kind of process wise? I really like that when you were saying, it was resonating with me, but I was just thinking about how we address it.
I guess I would add goal for who. So is this a responsibility of the practice, or is this more of a responsibility for the larger system? And our goals don't have to be their goals. It couldn't be. So I think that's important.
Ellen, if I'm just reflecting on all of our conversations, we were really responding to the data as it reflected what the members' needs were. That was my understanding. So that's the lens through which I know that I've been looking through all of this. And the members, just based on our data, I think Guy had started in the beginning saying that, we've been polling members. This idea of really having more access so that they could, or more capacity, I'll use that term instead, to really get to chronic conditions and targeted care management is really borne out by the anecdotal communication we've had with our members and also what the data shows us. So I guess the answer to your question is it's really more focused on what our members need. And I think we're trying to figure out how we can how we can pay our providers so that they can have a more capacity to better deliver what clearly our members have identified as their need.
I guess what I was thinking though is whose responsibility it is, because some of these things, to your second point, how can we pay providers so they do these goals for us? And sometimes it's not the provider who's going to do those goals. We talked about social needs not being, primary care's job. So I think we need to keep that in mind when we're talking about it, because I think if I looked at this, that's a lot to ask of.
It is. I agree. And I think the idea here is that where primary care can make a significant contribution to the management of chronic conditions and targeted care management, we'd like to create a payment model that allows for that to occur. It isn't that we would shift the entire burden onto primary care, because there's so many things that are wrong with that, right? It's unfair, it's unrealistic, it's all of those things. But to the extent that providers are giving us feedback that I've got too many patients, I'm not being paid properly for that. I could probably do a better job with my patient population if I had more payment, more capacity, more, to Alice's point, more partnerships with community-based organizations that could help with some of this. This is what I think we're here in part to really be able to say, what can we do with the levers that we have that can help create a better environment for you to help patients to the extent that you can get a better outcome. That's really what.
I think I was gonna, I tried to,
That's fine.
Question. Can't remember if you were at the meetings where we're discussing like outcome measures that we might think about using. Because I don't know if that helps to get to some of your point about like clarity. We did start talking about, so for example, like chronic condition management, we talked about like, well, there's a bunch of readmission measures and also like potentially preventable admissions. And I think, and Ellen had brought up the point of like, if we're going to use them, make sure we use something that people understand, and that's not a black box, but just to say that might help a little bit. And we did include it in it's a last couple of slides where we did start talking about those measurement pieces, because that may help define like, okay, well, we have these success, we think we're naming success, but then how do we measure it? And that might, I don't know if that helps.
Yeah, it's a lot. You can't manage what you don't measure. Everybody can think they're doing a good job, but unless you can tell them they actually and we won't know that, we've talked about this a lot. There's been a lot of trials to think that we're going to have an impact, and they just don't show up. They just don't happen, and they seem completely reasonable, but you get there and you go, that didn't happen. If we're not able to, we're going to keep throwing money after these things, because you can't stop programs once you start them unless you have a really good reason. And we've got a lot of things that have continued on, even though we're not sure it's really of value. So without being one of the boundary conditions to me is we can't measure it and we don't know what success looks like. We can't choose it as great as it could be. I think it's just a mistake to try and go down that path.
And I'll just say that I think we definitely understand and are aligned with that. Some of it does have to do with, we can measure something, but if we're not holding providers accountable in some way, maybe that's financial accountability or other quality measure accountability in some mechanism, it's hard to actually get those outcomes that we're looking for if we don't pair those together. And so that's where I think as we're having these conversations, we see them as we need to have them sequentially, but we also need to revisit them as we go through them because we didn't do a comprehensive outcome measure assessment. We just said, here's some that we think could drive towards what we think is success. Well, then this is kind of the payment is the enabler and also the accountability mechanism to a degree for those measures, I think.
And I think eventually it gets to an outcome. Sometimes you're gonna measure compliance and compliance alone will give you some sense as to whether you're doing what you need to do. That can be a place to go. It's not a favorite to rather have something that you're really seeing that will improve the health and well-being of the folks. But sometimes you gotta settle on compliance if all you've got is a process measure that you're trying to implement.
And I would just say that I like to use less compliance and more like is someone doing, and did the provider do a good job of actually getting that person to that point? Right. And so what are those measures that may be more patient-centered or person-centered to make sure that we're driving towards the outcome that they might care about? And that may ultimately drive all of the components, like if the provider's providing presenter care, maybe someone's more likely to actually go along with what the provider's saying because they trust them as opposed to just feeling like they're being told. And obviously these things, they stack up and we may not be able to do all of them because of redesign is complicated and we may need to focus on what can we really do? How do we align with what other payers are doing so that we can maximize benefit? Or, I think these are some of the considerations we all have to have as part of this conversation.
And I think a lot of this requires a team-based approach to care. This is not all the MD or the NP in the room one-on-one. So I think we always need to keep that lens that, whatever payment model we're creating, does it support that? It is a lot more efficient to get 20 diabetics in a room and do an hour of education than me trying to do 2 minutes of education in a 15-minute visit, so.
I saw that Alice has her hand raised. Go ahead, Alice.
Yeah, thank you. I actually would support what the discussion was having. But again, I want to challenge us to think outside the medical model a little bit. You have access to a lot of data. You have behavioral data, you have CHN. There are other data pieces that could be tracked. But if you were really thinking about how is this person thriving and are they able to, let's say, a question could be, did they work in their full schedule this week? Or, we looked in our last wraparound project around inpatient stays. We had no impact at all on ED utilization because a lot of folks use the ED because it's their primary care. We used a patient activation measure, which was very interesting, actually. The PAM, Massachusetts, a group out of Massachusetts designed it, and we had some very good outcomes around patients feeling like they can manage their own care. When you're thinking about kids, one of the things we're tracking is their chronic absenteeism. We're going to have an impact on that. We're going to have an impact on them not going to DCF. And then that begins to think about all of the different savings you have, right? I know Medicaid doesn't count, if a kid, goes to school, that's not a count on your end, right? But it may be a count 10 years from now because they may get a job where they have private insurance. So, I think we have to really be a little bit broader in our thinking. Because when we just restrict it to the medical HEDIS measures or, other measures, we need to, you're not really tracking the thriving of the individual. Thank you.
Thanks, Alice. I think Alice raises a good point, right? What's the member's responsibility in all of this? She mentioned the patient activation measure. So CHN has actually just started to use patient activation measures to look at the effectiveness of our care management interventions and then also look at outcomes like, does this reduce readmissions or does it reduce unnecessary ED visits, targeting patients who have a higher engagement level, therefore in their patient activation score, so a lower risk score, and then seeing if we can increase their engagement through care management engagement.
So that's a good segue into the chronic condition targeted care management and just a bit of a discussion and pressure testing on each of those payment models. So in order for us to support that priority, folks have thoughts on relative payment models or advantages. This is also a good time to kind of double click on particular either specific settings or practice size. You know, we talked a little bit about small practices, but also rural settings, and we talked earlier about traditionally marginalized populations in urban areas. So just thinking through those dimensions as well as we look at this is going to be important.
I think to Joe's earlier point, there's a variation in how what capabilities practices have developed to do population health management. I think it's, you know, the Massachusetts model, which is tiered and lets practices attest to what level of services they can deliver, is really interesting because, again, it's like, yeah, we can do this or we can't do that. So we're going to go to a lower level, and we want to develop the infrastructure necessary to move to a higher level of
I think one of the issues to think about is two things strike me. One is that, again, when I look at what other payers do, whether it's Medicare or other groups, they don't have one single model. And that's one of the things I'm just reflecting on as we're sitting here. There's again, a glide path of models. They may have a standard model, which is their favorite model they'd like to bring out, but there's almost always a more basic model for beginner organizations. And then there's either defined or opportunities to develop more complex models, or there's an expectation in many cases that you'll graduate to more complex models after so much time in the kind of more moderate models. So one of the things I'm thinking through here is, and one of the struggles I think I'm having is that to try to pick one model that kind of covers the spectrum of provider groups, I think is challenging. And it also challenges to think about what is our target provider group. Previously, DSS has a very kind of almost a bimodal model where on the PCMH model, it's very practice, small group focused, also focused in some large organizations, but the capability for individual practices to participate. The PCMH model is a more complex, more organized model that smaller individual practices generally are not going to be able to do. And so I think we have to think through is that what are we targeting? Are we targeting the more complex, more organized, quote unquote, advanced networks as we've defined them? And then we'll bring along as many of the groups affiliated with that. And then what do we do with groups that are not affiliated with those networks? Do we have something to offer them? Because if we go to kind of the more practice-based groups, we're going to not engage the larger networks as well. So I didn't have an answer to this problem there, just was kind of some outline to it as I was thinking about it.
Does that really, I just come back to not thinking about, I disagree with Jim that on thinking about compliance, because I'm thinking a lot of failed programs are get 100% compliance. So sticking to outcomes, if a practice wants to do it a certain way and it works, then why would we mess with that? I think we should wrap around it. Maybe it works really well for people with diabetes, but not so much for heart disease, or works for children, but not, you know, if it's a family practice. And I think we should be looking at outcomes but allowing lots of flexibility. One thing I don't love about CMMI is, yeah, you're in at track 1, but within a certain number of years, you got to be in track 2, and then you got to be in track 3. And there's a lot of anxiety around that, and trying to look at the numbers and how can we fit our, you know, round peg into their square holes. So I think flexibility about the tracks, but making it clear that you're welcome at any track.
Yeah, I would agree with you. That's a good example of a track model, CMS's program, but there is, I would not, for this purpose, recommend the kind of forced graduation that is in place there.
So Joe, you had mentioned that in your view, the great majority of the primary care practitioners are affiliated with a larger group or system, like, and probably that means that of those not Medicaid beneficiaries not served by one of those groups, they're probably served by a primary care provider with some sort of affiliate. That's not everybody. Some folks may be still independent or very small practice. So one of the questions I have, and this sort of tries to bridge to Jim's point about, can we be more specific about what it is we're trying to solve for? And Keith's comment, well, I don't want to narrow, you know, I don't want to sort of give up on the aspiration. So, and also harkening back to the measures that are proposed previously. So it seemed to me that diabetes management and diabetes related admissions was something you wanted to, that a measure around both potentially avoidable admissions, but also diabetes management was one. Hypertension management was another, and asthma and related admissions was a third. All of those are pretty common problems in the Medicaid population and have both secondary prevention and primary care value. To more effectively serve just say those three chronic conditions, one would, based on the data we've seen, want to screen for and make sure you're addressing behavioral health comorbidities, either within the practice or through referral. You're going to want to identify at least, so setting aside universal HRSN screening, for those patients, you would want to be able to solve for the health-related social need barriers. That there would need to be some sort of coordination or navigation function so that those folks get to their specialist visits or they get their care coordinated after an ED visit or what have you. And maybe that would be a CHW, so you have somebody who's better equipped to bridge the, say, culture gap. And then the last thing is, I would assume that for hypertension and diabetes especially, some sort of nutrition or lifestyle support is part of that, the sort of healthy eating and activity. And so just sort of thinking about the sort of core package, if you are focused on the conditions where measured performance seems to be, there's an opportunity for improvement. And the key capabilities that would support management that are in these other domains, HRSN and behavioral health, that seems to me to be a way to draw a circle around a significant scope, but not boiling the ocean kind of approach. And the question then for me, for those, the two of you who have, I don't know who else, Dr. Sproul, you're in a network, and Polly, sorry. Too far on the
Like
left.
right here. That's a small one.
Sorry about that. A fatal error for somebody who represents the association.
Especially when you sit next to it.
Yeah. So I guess what I was wondering was how much is that sort of that kind of a focus and those kinds of tools consistent with what you're directionally trying to do with your commercial model?
I'm sorry, I really want to acknowledge Alice has been waiting for quite some time, if you don't mind, and then I'll bring back to you.
I don't know if I'm sorry, I didn't put my hand down, but I want to echo what Mark said. You know, we did asthma project through wraparound. I presented at the Connecticut Health, the Hospital Association, and all of the wonderful putting on airs and all of the other programs are amazing and very helpful. But one of the things is they give a ticket to a warehouse to be able to get the covers for your mattresses or the HEPA-Vac or whatever. And a lot of our folks couldn't get that because they don't have a car. And so they couldn't get that, get those materials. So actually physically having someone drive them, pick up the material, and also a lot of single moms who are, you know, dealing with, you know, putting a mattress cover on, you know, you need help. You can't do that by yourself. And so there's like some very important practical interventions that made an enormous difference in people's lives to be able to, you know, get from the referral, the, you know, the materials to actually getting them to the home, into the house. And those, you know, and certainly education, which helps a lot around using, you know, all of the pumps and stuff. But asthma was the largest issue we had with the adults and with the kids in the wraparound project.
Yes, go ahead.
So I wholeheartedly support the tools that you've proposed, whether it's nutrition, behavioral health. I worry that if we're only focused on the chronic disease, especially diabetes, hypertension, we're really ignoring the pediatric population, because so much of what pediatric primary care is not about diabetes and hypertension and even asthma. Well, asthma is a larger a larger chronic disease for pediatric populations. It's still a small proportion of all the kids that we take care of. So I just want to be very careful about, I think the tools are important. I think the tools can be applied. I would include developmental services in the behavioral services. Hopefully we can include that because I think that's as important as the behavioral side. I just want to keep, since I'm the only pediatric representative on this group, I just want to make sure that we're not forgetting about those individuals under 18 who the investments, behavioral, developmental, nutrition, prevent all of these things in the future, the diabetes, the hypertension. I just want to make sure that we're not forgetting that. And I think if we focus too much on the chronic disease, we ignore what the value that primary care and pediatrics can provide.
Maybe just add quickly, I think one thing we've discussed early on was that at least part of the goal setting was with this process was to kind of think about a broad-based program, but really thinking that as a phase one, whereas there need to be secondary processes where we think about specific populations that may need a tailored program. In pediatrics, I think I would argue it eventually would need its own kind of focus area as a defined population. And we may need to do that for additional things, but I think it's hard because we need a broad start somewhere. And obviously we need to be thinking broadly, like how can we generally start thinking about transitioning providers and how can we make some alignment? But then also there are going to be specific populations that at some point we do need to make sure we're building programs for that help make sure we're enabling that preventive care for pediatrics that is going to look different than for a 65 plus population or a 45 plus with a lot of chronic diseases. And so is there something that we can do that gets us in the right direction that we can build off of in the future?
I also just want to reflect too that, the different provider groups can take different strategies, right, to build the capabilities. So when we think about the fee for service, what is a billable service, earlier, I think last year, Medicaid added the ability to bill for the coordination of care behavioral health payments. That was not a code that was enabled with the Medicaid program previously. There are other billable codes for, e-consults, transitions of care, complex care management, all of those should be enabled and give us an opportunity to determine, what programs and services we want to take advantage of. And then there are things that are not reimbursable, potentially like navigation services or referral programs. And those are where some of these, kind of add-on incremental payments can also help in developing capabilities that make those connections to other services and resources. So I just want to point out there, even within fee-for-service, there are other types of billable services that Medicaid historically has had variation from in other payer models, and that we should also think about, those capabilities that may be important to developing as well.
Mark, just to say that we took exactly your point. That's pretty much what we did. We took hypertension, diabetes, risk stratified it by so best as we could and have approached. And there's been lots of lessons learned, but it required us to change the care model. When you suddenly have 110,000 blood pressures you have to get checked every year, you start thinking differently than having everybody come into the office. And so it's exactly what we've done, and we've seen some good success with still a lot of work to do, but it helped us get our arms around how do you manage a large population of patients with a very common condition and do it well and be able to measure it and get out.
Jim, I'd be curious to know if those lessons learned from doing a protocol around hypertension management were translatable to other chronic diseases. Like, did you feel like that built up a capacity that we could then easily translate or versus not? Because I think the question is, do you identify these are the top 3 priorities from a public health perspective? We're going to reduce disparities, we're going to improve population health, and hypertension, diabetes, asthma. I would say tobacco is still kind of up there, even though the proportion of smoke that still smoke are low, but it's still a very high burden condition. But I guess the question is, if we're very specific, saying we're going to focus on hypertension, then you run the risk of saying like it's just too focused on one thing and we're losing our capability to address other chronic
It's a
conditions?
really good question. We didn't find that. We monitor a whole bunch of quality, HEDIS measures and other things. And we certainly didn't see a deterioration because we were focused on these two. We also chose them because we were not performing well in it for lots of reasons. And so it was a real opportunity for us to do it. What we liked about it is the fact that it was going to have to require different solutions. We're going to have to find different ways of doing this besides bringing everybody in for their usual, office visit, because we didn't have the capacity to bring those people in all the time. And a lot of people who have, who are managing hypertension, are like, I don't have time to do an office visit. My blood pressure's been fine. We can manage it from home. So yes, not all, but a lot of the lessons we learned there were very much, you had to solve for a logistics problem. And I say this all the time. It's not the medical care we're struggling with. It's all the logistics around medical care that we struggle with. That's what we don't do well. If they get in, we take really good care of them. And I think that's true of all the providers. It's, are they in? And do you know? And that's where we struggle. So I think it is, we'll see if we can continue to broaden it. But so far, it's taught us a lot.
I guess one of the questions, Jim, is what's an enabler of that? We talked about coming back to payment, sorry, we'll jump in, because I think one of the questions comes to, like, what is the base payment model that helps enable that as you're learning and trying to figure that out? And I think we've heard some of a bit of both, that if there's some utility at fee for service, and Paul, you just said like enabling a bunch of codes, but there may be some benefit to having some additional flexibilities, and that can include non-visit functions as well. I think that's been alluded to. What is the enabler in your case, Edward?
Fair amount is virtual care. There's no question that the Epic model, being able to communicate with patients, helping them self-manage was a big part of what the infrastructure was. I think we still have a lot of learning and opportunities around remote patient monitoring to solve this problem a lot easier than a whole bunch of docs seeing patients. So it's all of that continues to push us. But there was a whole lot of, this wasn't primary care doing all this work. It was a lot of support staff who were really doing the outreach and the tracking down and the care management, and you need to get in. And then when you found those people who were not well controlled, it was not appropriate medical care, getting those people targeted in and getting them, meeting them where they are, so you can make that as easy as possible, was all the lessons. So yeah, it's it for such a simple thing that we probably should have been doing for the last 20 years. It was striking the amount of work we really had to put in to get to the kind of performance that really I think most patients expect you're already getting. So
in terms of finance, because that's expensive to do. So what encouraged you to do that, and what helped you do that?
Yeah, I tell the leadership all the time, I'm not making any of you guys any money with what I'm doing. It was very much it's the thing we have to do to get prepared, because as we own the risk of these patients, and when we're finally going to get into an alternate payment model, the healthier they are, the less they're going to cost us. So this is very much an investment in where we're trying to go. And if we don't get ahead of it, a little bit of anticipating that in order for us to embrace really innovative payment model, you can't do the payment model and hope to build it afterwards. You better be doing it, and then you let the payment model align. And we sort of went down that path, realizing that yeah, there's a lot of work we're doing, we're not getting paid for it, but it then allows us to be confident that we can say when we're ready to flip the switch on a payment model, we know what we're doing.
I would echo that, Chip. I mean, that's been our experience as well, as successes that we've had have been a lot of the focus on the quality, the outreach, engaging patients, getting them in. But it's taken years of developing that infrastructure. And I think, as you said, Joe, from where we were as a state and having these capabilities, 5+ years ago to now, some of the advanced networks are in a much different place to be able to start to take the ball on this and advance it.
So then, if this is a question that I'll pose though, so are we considering then a payment model that helps primary care providers to build a more robust network of supports that does a lot of that work and not necessarily driving people to the offices? So I would just made a note, so are we thinking about not redefining, but creating a different compensation model for the care delivery, or are we going to pay for the care? And they're not mutually exclusive, that providers are already providing in some instances, right? They've already created an infrastructure within the resources they have available so that they are going out and not them themselves, right? But their staff or their, you know, they're partnered with a community-based organization. They're doing all of the legwork, but not necessarily their offices aren't necessarily being properly compensated for that. So I'm just trying to make sure that I'm understanding what.
I think it's both, right? I mean, the underlying Medicaid fee structure, I think, is tagged to 2014 Medicare rates. So like that, you know, for folks that don't know, that structure has been fixed. So that underlying payment structure has been
Not fixed as in no longer needing repair.
sorry,
Stable.
has been set and has not increased over time. So I think, and Brad, you alluded to this, I'm not sure if this is what you're talking about in terms of the rate structure review, is, you know, Medicare evaluates their base payments every year and updates their payment structure. And thus far, the state has not made adjustments to that. So, you know, it would be like you not getting a raise, you know, and your expenses keep going up, you know, with inflation and other things like that. So I think we're aligned in advocating for an adjustment and a model that updates that base payment structure so that when the patients come to the practice, which they will do and we want them to, that those providers are reimbursed for the care that they're providing. And then that incremental payment supports the investment in the data infrastructure, the care navigators, the digital outreach, the remote patient monitoring, all of these things and capabilities that we're building, but we can only build so much of until we get another source of funding. So that would allow us to then up the ante, hire more CHWs, hire more LCSWs to target the specific goals of this population.
So then I think what I'm hearing fundamentally, please, doctor.
Oh, good.
Is that in terms of a very broad structure, we are in alignment around a base payment and then a payment that sits on top of that or complements it, right, as a structure. Now, and we will not do this today because we've got 20 minutes, right? Now we really need to talk about what the details of that are that allow for really the second part of what you talked about is really allowing for primary care providers to do all of the things that you just discussed in a way that provides appropriate compensation and actually, Dr. to your point, gets the outcomes that we're looking for. Okay. I just wanted to summarize what I think I've been hearing for the last 20 minutes. Okay, great.
And I don't want to lose what Alice is saying, because I think you all are in a unique position that you are larger practices that can do a lot of this work internally. There is going to be a need across a continuum for some practices to actually partner with the CBOs. And to her point, I don't want to lose the PMPM need for some of those organizations, which was a part of our earlier discussion as well.
I think, and also just adding that, I think to your point, like there's also a tiered need, or can track, you know, having different layers for different providers, as well as recognizing that, you know, and I'll just come back. We distinguish in our categorization of incremental versus base, like that non-visit function in the incremental payment, but realistically that can be included as part of what you would consider a base payment, because that could be a care coordination per member per month payment or an enabler that goes along with that as part of your kind of quote unquote base payment, which could go along with exactly what we were discussing today. And I think Commissioner, as you kind of summarized. So just to say, go ahead, Jeff.
I just want to make sure that.
Oh, yeah, that's right. Oh, someone has, okay.
This is a very quick point. I just want to clarify what you had mentioned is important for the smaller groups. I do think, just to clarify, that even for the larger organizations, that kind of PMPM structure, that extra will still be important. I think the difference is many of us may be able to manage many of those functions internally, where you're correct, smaller groups will have to externalize it. So I think it's a matter of being flexible in how that funding is implemented by the organizations. So there is going to need to be some, I think, you know, financial support over and above the kind of base payments to help build the program and build the programmatic structure.
Hello?
Angela, can you hear us here on my computer? Hold on, let me turn down my volume.
Yes.
Okay.
Can you hear me?
Something happened on our, I'm just gonna have you speak on my computer and turn you around, okay? So sorry about that.
No problem. Just for the sake of time, I understand there's a lot still to cover with just a few minutes, and I just would like the note taker at some point, maybe after, to make sure the comments in the chat are included in the written notes.
Definitely.
Because we don't have time to interject for the sake of time. Thank you.
Yeah, Angela, I hear you. I am the note taker and will absolutely be attentive to the chat after the meeting. If there is anything that those in the Zoom room do want to add to the conversation, we could also offer an opportunity for that if there's anything that you want to comment on verbally now.
Yes, I couldn't tell who was speaking. So I dropped it in the chat, but the comment about logistics versus the quality of care, like once folks get connected, Connecticut does well. That's a great point. But it points to the need for Connecticut to address the inequities and the systemic racism that lies in people not having appropriate access. So if we could solve for access, we might be able to move the needle. So that's kind of what I wanted to make sure got captured.
Thanks.
Thanks, Angela.
When we were talking about, and I think when we're talking about things like blood pressures, patients don't necessarily have a huge care about where that comes from and who gets partnered. But once you start partnering with community organizations and some of the other things like nutrition and lifestyle, patient choice is really important. A health system may say, we have an arrangement with, this gym, and so that's where, we're gonna have offer that, and that may not be realistic. Somebody doesn't have an ability to get there, doesn't have a close to their family, but maybe has a safe neighborhood where they can walk. So we want it to be, and in terms of getting language as well. So one size is not necessarily gonna fit all, and I think we need to, I'm not saying take that choice away from the provider, because the provider needs to be comfortable with whoever's providing that data and that, that support, but also the patients.
I'll just say, I think there's obviously a balance, and I think, Ellen, your point about patient choices and human choice is really important. It'll be a balance. Like when you go to the provider, you go to your physician, like, do you pick the MA you're working? There's a certain level of that we have to allow for some provider choice, but also make sure that patients can move and do other things if they really want to. And so that'll be a balance, because if it's like, well, you can pick any CBO to work with, that might not be tenable for the primary care provider, but we obviously want to get that balance right, I would say, as we think about it moving forward. I know we're close to time. I know we're having a little technical difficulties, so I wonder if that's okay. I just want to check with the folks online. Could you hear Ellen still talking?
We hear you, but not her.
Okay, we can do a little round robin. I know
Yeah.
we're kind of try to talk about like next steps and wrap up a little bit. I know we had a robust conversation, and Guy, I don't know if you want to jump in. I can also pass off my computer. Yes, please go ahead. Oh, I got you. I got you covered. Are you on it, Tiffany? Okay. We're moving around to get better audio requests.
All right. Here you go.
Thank you. I just have a very brief comment, and I just want to say, I would just ask when you decide how you're going to administer whatever program we decide upon, that we be thoughtful about the administrative complexity that is in the program design. And I will speak with the experience of the prior programs that the level of complexity in the PCMH Plus program was quite substantial, very disproportionate to any other type of value-based program, including with federal-based programs. And so I would just ask that, and all that does is just takes resources that the provider groups have to put in place. And I know organizations were hiring full-time people to actually manage the program, not the patient care, not the delivery of it. And that is not the norm. And I just would just put that out there as something to think about, that the level of complexity, if it could be simplified, would be important. I'm sure there's agreement from others who.
Ditto.
Thank you.
Yeah, I'll just highlight that obviously the balance between aligning outcomes that are important for members versus and we talked about this previously on requirements versus focusing on outcomes. And obviously outcomes makes it a little bit easier than if we have requirements, but obviously there's a balance. And so I know that'll be part of the conversation. Polly.
And again, I think also, you know, and I know obviously the focus on health equity is super important for this population. Over 5 years ago, that was not the focus on many other value-based populations. That has changed. So I think it's very well aligned with other capabilities that we're developing. And I want to like reinforce that again, like we're developing those capabilities, but again, the ability to have the, you know, payment models reflect that is still, you know, evolving as well. So I do think that's an area where, again, you know, we see there's a really strong connection. There's other payers that are coming to the table in that regard. And I think, you know, building that into this model in a way that's complementary and helps move us further faster will be very well received as well.
Thank you, Polly. Guy, I might turn it to you. Oh, sorry, Angela.
I'm
Angela,
sorry,
do you
that
wanna
was
weigh in?
probably a legacy. Let me.
Oh, maybe took a hand down.
Maybe
it was
not.
that
Okay,
might have been a
Angela,
legacy
sorry.
hand. Sorry about
Just wanna
that.
make sure we got that. So we're coming close to time. Let me just take a step back. First of all, thank you. Thank you for being here in person. Thank you for being online. We did not accomplish everything we wanted to today, and that's fine. I think today's discussion was really productive. If I take a big step back and think about the 5 goals that we've talked about and the ways that we want to measure it, I feel good about the progress that we've made towards at least beginning to think about where the rubber meets the road, which is funding. I will flag that funding isn't the only option. I think part of the discussion should also be what DSS can do to help support our providers, data, infrastructure, the important care management work that CHN does. When I think about what we're going to do in the next times, I want to caucus with the team, so not making any final decisions here, but what I'll posit is that we spend a lot of time on chronic condition management, which is appropriate. It's the #1 goal that we identified before. I think that's helpful. We touched a little bit on access and obviously health-related social needs, including the SPADE that we talked through. I think in the next session or two, we'll want to dive deeper on the remaining goals and think through both the base payments and the supplemental payments. Like, how do we achieve those outcomes and how does it make sense to pay for them? And I think, Jim, to your point, I think that will be a little bit more of a grounded discussion if we're saying, okay, concretely, we talked a lot about access. We talked about how we'd measure it. Okay, how do we help set the incentives and create the structure for our providers to give our members the type of access that we'd like? So that's the preview for the next time we meet. It'll probably be virtual. But we'll think about, in particular on access, how to get the payment model aligned with the goals that we set and the ways that we would measure them. And we like to end meetings early. So unless there are any other comments, I just want to say again, thank you. I know this is a big investment in time. I want to say I'm listening, my colleagues are listening. I certainly know the commissioner is as well. And I think today's discussion was really helpful. So thank you.
And I'll just flag since, it's actually, great. We can see, I'm not sure. So something, not sure what happened, but just flagging the next conversation is scheduled for the February 8th, which we're planning on. We knew we'd need follow-up and obviously we do. And that is, will be a virtual meeting and we'll be following up with any further information at that time. So thank you all. February 8th. Thank you again for those online. We really appreciate it. And we look forward to talking further with you at the next time. So see you all soon.
Thank you very much.
I know, we're only here.
I'm not sure.